Don't wake this baby.
A zuba min kuninta. A zuba min kuninta na ce.
Frank, don't make noise. I don't want this baby to wake.
Hello, good morning. Barang buat dia semua.
Babu. Kaga babu black hole.
Okay, host kai disable the screen sharing ko? Okay, good morning, everyone. Hello, good morning.
Morning, sir.
So, how was our week? We really had an eventful week. Actually, sorry for starting late. There was sanitation in Kano. We have to observe sanitation, and um, we have to travel from our places to the rehabilitation center. At least it will take like an hour or 30 minutes for us to reach. Therefore, we sincerely apologize for starting late. And I am sharing my screen. Have you seen the screen?
Yes, sir.
This meeting is being recorded.
Okay. We are starting with cerebral palsy. That is the definition, and we go gradually until we reach to today. Everyone is welcome. By way of definition, we say cerebral palsy is a disorder of movement and posture, causing activity limitations that are attributed to non-progressive disturbance that occur in the developing fetal or infant brain. Okay, if we want to break down the definition, we said it's a permanent disorder of movement and posture. What they are saying here is the damage done in the brain is actually permanent, but we said it is not unchanging, meaning that when they undergo rehabilitation, they can achieve some motor milestones that hitherto they were not able to. Therefore, but the disorder of movement or whatever causes the disorder of movement in the brain is permanent, but movement can change. That is environmental influences like that of the physiotherapy management. They can also get improvement as the central nervous system mature. Okay, then they said this limitation are attributed to non-progressive disturbance. We said the disturbance that occur is permanent but non-progressive. In essence, if you are managing a child with CP and you see the child that is able to sit now has turned back to lying down or having poor neck control again, meaning that the child's condition is deteriorating, there is no CP. It is something in the brain. It may be an infection. It may be in any intracranial space occupied lesion. It may be cancer or tumor. It may be anything, a form of edema in the brain, probably, that is progressive. But if it is for a child with CP, it's actually the disturbance is permanent, but it's non-progressive. And then the last part of it, they said developing fetal or infant brain. Here, two things are involved. Yes, when we say fetus, we mean a child that is yet unborn, and then infant, a child that is born probably within the what do you call it, 2 years of life. Then the neonatal period is between birth and 1 month, 4 weeks. Therefore, what they are saying is, whatever happens to the brain, any lesion to the brain that occur when the child is in the womb or when the child is born up to 2 years of life, if it really causes abnormality of movement and posture, then it's likely going to be called CP, because there are some postnatal infections, or at times what do you call it, rhesus incompatibility, or at times jaundice, that can affect the brain even after the child has been born normal. That is still. They said even though cerebral lesion is permanent, its clinical manifestation change as the child grows. Therefore, changes can occur due to interventions. Some changes can also occur due to maturity of the central nervous system. As the central nervous system is becoming matured, and if it coincides with adequate physiotherapy, then the child is likely going to get improvement. But the lesion in the brain actually is permanent. They say the motor skills of most children with CP improve as they grow, but at a slower rate. Yes, that is why we used to give what do you call it, allowances. If a child is supposed to walk by 14 months of age, that is 1 year, 2 months, and that is delayed up to 18 months of age, we still call it for a CP within normal. There is just little delay. Okay, then to the next slide, associated impairments. The hallmark of CP is the impairment of movement and posture. Therefore, whatever brings the mother of a child to physiotherapy department is that of inability of the child to do things that other children could do, or to perform activities that other children could do. Other children can sit, the child cannot sit. Other children have good head control, the child does not have. Other children can suck breast, her own child could not do that. Other children recognizes their mother, her own child does not recognize the mother. Then something is happening, then she takes him to the hospital and they say this is CP. Therefore, that is the hallmark of CP. But apart from CP, the hallmark of CP, there are other associated impairments, meaning that lesion in the brain can also come along terms of other lesions in other areas of the brain. Therefore, we can have lesion, what do you call it, impairment of sensation. That sensation is an all-encompassing word. Sensation here means sensation of touch, sensation of vision, sensation of hearing. Therefore, impairment of sensation is general sensory modalities. Perception, impairment of perception. We, at times, if one is not careful, a child that usually have problem walking or he falls easily, it may not be as a result of what do you call it, poor vision. But though poor vision is part of good perception, but perceptual problems are very big. A child sees what do you call it, a staircase, but that child could not discern that this staircase is up to 2 inches or 4 or 5 inches tall, that you should be able to raise the leg very well on the staircase. Then that is perception issues. Perception issues is like, by the way they define perception, is the ability to translate sensory impression into psychologically meaningful information. Let me give you an example of perception. You are sitting down and somebody approaches you with a knife and you run away. What you see is a knife. Why do you run away? You have already interpreted that that knife is going to harm you. That is perception. Therefore, you are walking and you saw a gutter and you now draw backward and you now jump. Why did you jump? You have already interpreted what you have seen, that this thing requires that I should have momentum. If not, I'm going to fall into the ditch. That is the same thing. If a child with CP lost perceptual ability, then walking will be difficult for the child until you understand that, yes, this child actually does not very well, does not gauge height very well. That is part of their perception. Then cognition, ability. Please, communication is part of cognition. Cognition is, they are like synonymous. Each one, what do you call it, strengthens the other. Therefore, cognition has to do with memory, has to do with understanding, has to do with obeying command. Therefore, cognition is everything. Therefore, if a child is having poor cognition, is likely going to be mentally retarded. He cannot obey command. He does not recognize mother. That is part of cognition. Interaction, ability to understand, ability to store things in the memory. They are all part of cognition. Then communication. Both, what do you call it? Both verbal and non-verbal communication. Yes. Can the child talk? Can the child respond to spoken word? Can the child understand gesture? Can the child do gestures? That is it. Then behavior. Does the child behave? No. May be having what do you call it, associated impairment like attention deficit hyperactivity disorder. Then by secondary musculoskeletal problem, the child with CP probably having spasticity is likely going to suffer from contractures. I know there is difference between contracture and deformity. In contracture, soft tissues around the joint are contracted. Therefore, like individuals having TA tightness is a form of what do you call it? Can give example as a form of contracture. You may have somebody who has bones injury with all the tissues around the joint having keloids and all these things scarce. Therefore, they may restrict joint movement. They are all contractures. But somebody is who underwent orthopedic surgery, the skin is very okay, everything is okay, only that the joint surfaces are gone together. That is stiffness. Therefore, stiffness, contracture, all those ones are secondary musculoskeletal. Individual is going to suffer, including spasticity and all these guys. They are secondary musculoskeletal problem. Though there are some what do you call it? Some authors like put together motor impairments together with spasticity. Whatever it is, whether you take it as a form of motor impairment or associated impairment, spasticity is a very big problem to individuals with cerebral palsy. Therefore, these are some of the what do you call it? Associated impairments children with CP used to suffer from. Chronic pain. Therapists must take into cognizance pain is actually can impair movement. Pain can bring a lot of hardship to the child. Therefore, the little massage we used to do usually help them to feel comfortable and reduces the cry whenever the therapist is managing the child. Cognitive and intellectual impairment, we have studied. Impairment of speech. Then musculoskeletal problem. Yes, one big problem is hip displacement. A child who is having what do you call it, quadriplegic CP, and he is he is into flexion, what do you call it, contraction. Therefore, whenever we are mobilizing, we must ensure that our mind goes to the hip, because we can easily cause hip displacement when we apply too much force. Then seizure and epilepsy. Then we have behavior disorder like attention deficit activity disorder, urinary and what do you call it, fecal incontinence may be part of it. Then we have sleep disturbance. This is another very big problem in children with CP. It may be as a result of disturbance that occur in the brain. Therefore, primary sleep areas may be affected, or maybe as a result of inactivity. The child has been lying for some time, for some years, for some days. There is no input from the therapist or the mother to move the child. The child is always sleeping. The child will oversleep, that it does not sleep again. Or another issue disturbing sleep may be pain. The child is having secondary musculoskeletal pain, may disturb sleep. There may be so many causes of sleep disturbance in a child with CP. Then we have visual impairment. That is part of the cessation we are saying. The child may be visually impaired or may have total blindness. You can see in some children. Then we have dysphagia, unable to eat orally. Therefore, some of them, if it is so severe, they would have to undergo surgery where some tubes may be placed in the stomach where they could be fed directly via tubes. Then we have hearing impairment. All these ones are associated impairments. Then risk factors for cerebral palsy. We can have maternal related risk factors. We may have child related risk factors. Then in the maternal related risk factors, we have thyroid condition. We have what you call elevated serum thyroid. Or at times the mothers may have low thyroid hormone. Therefore, the most important thing we should understand is that thyroid hormone, called the thyrotropin, actually is part of the hormones that helps in the motor development of the child. Therefore, if the mother is having low thyroid hormone, the child is likely going to have what do you call it? Impairments in his motor development. Then we have infection during pregnancy, and we call these ones as a group touches organisms. We have toxoplasmosis, we have rubella, cytomegalovirus, we have herpes simplex viruses. These ones are the ones that affects the child, a form of infection that through the mother the child can get this infection. Normally, when mothers go for antenatal, they usually tell them that you have infection. Normally, they will not say which infection, they keep treating. That is the beauty of going for antenatal. Toxoplasmosis is gotten from Toxoplasma gondii. If you have a house cat, the house cat gets Toxoplasma gondii from what do you call it? The mice in the house. If they eat rat, they got Toxoplasma gondii. And then if the mother gets it through the feces, if she's the one clearing all the feces, she may get it. If she is immunocompromised, then this is going to have impact on her child. Therefore, we have preeclampsia, toxemia of pregnancy. The mother is having hypertension and with some other factors like protein in the urine. Whenever a mother is pregnant and they do test and they found through protein in the urine plus hypertension, is a likely what do you call it? A result that is telling them that the mother is likely going to go into toxemia in pregnancy, is going to affect both the mother and child. Bleeding during second trimester, meaning that prepartum or postpartum hemorrhage, all these ones are likely going to affect the child. But one basic thing about it is that they said through bleeding and through what do you call it, bleeding, infection do set in, and it's likely going to affect the child because through bleeding there will be communication from outside and the womb, and the child is likely going to become infected. The multiple pregnancy, where the mother is having more than one child in the womb, the other child may be pressed. Usually the child is going to have intrauterine growth restriction. One will be big, the other one will be small. At times they remove if there are more than 2, 3, at times 2 babies will be big, the other one will just be compressed in one part of the womb. It's likely going to cause CP. Then infant related risk factor. One is prematurity. If the child is not born up to 38 weeks of gestation, then some systems might not be fully developed, and the child may not be ready to come out. The system may not be ready for living outside until the child is placed in a, what do you call it, in a supportive care, in a special care baby unit. Then intrauterine growth restriction, we have said it, inability of the child to grow within the womb. It may be as a result of multiple pregnancy or other factors. Maybe probably the mother having some fibroid or anything that suppress the growth of the fetus, or it may be hormonal. Then we have low birth weight. It's one of the predisposing factor. The child may be having low birth weight between 2 to less than 2.5, or maybe having very low birth weight up to less than 1.5 kg after giving birth to. Is another sign that some systems are not likely matured. Then we have acute intrapartum hypoxic events. Therefore, maybe something like placental insufficiency. The child does not have enough, oxygen from the mother due to insufficiency of blood carrying oxygen. Though the blood of the mother and the child does not mix, but what happens is the child gets oxygen from the mother via what we call the gamma hemoglobin that used to extract a lot of oxygen from the mother via the placenta. If that does not happen, something is likely going to happen. The child is going to have hypoxic event. Then we have moderate to severe encephalopathy. Usually, these guys are the ones that we say they develop, asphyxia. Then neonatal seizures. The child may develop serious seizures that may be a predisposing factor to CP. Then we have neonatal infection. In neonatal infection, we may have aseptic and septic. We have meningitis, is an septic. Aseptic may be encephalitis. I have managed a child that developed cerebral dysplasia due to viral infection. Is an aseptic infection. Therefore, they will tell you is an infection. Then we have hypoglycemia, where the child is having hypoglycemia. It may be, in some instances, it may be maternal related. Usually, one predisposing factor that is maternal related is maternal diabetes. The mother has to be treated by a specialist because at times when the mothers are pregnant, they may become diabetic, pregnancy-related diabetes. Therefore, they have to be managed by a professional. The issue is that as she is managing high blood glucose, the child may likely going to become hypoglycemic. Therefore, the person managing the mother knows what drug to give such that the mother would maintain her normal blood sugar and the child will not be hypoglycemic. Then jaundice. Yes, usually there is what you call physiological jaundice when the child is giving birth to. Therefore, as the mother helps the child, manage excess bilirubin. Now, when the child is outside, the body would have to manage excess bilirubin in the body. If not, this unconjugated bilirubin will now cross the blood-brain barrier and causes what you call kernicterus. Therefore, jaundice is icterus. Therefore, usually the children that are unable to clear unconjugated bilirubin, which is the product of hem moiety, breakdown of excess red blood cells that die. Therefore, the body breaks them out and then dealt with the hem moiety. The unconjugated bilirubin will now accumulate and pass through blood-brain barrier. For the child that is able to clear it off, she can. The one that was able to clear it by himself, he may need either blood transfusion or phototherapy or some medications that would help. If not, the child is definitely going to develop kernicterus. Then we now have placental abnormalities. We have said it. We have birth defects. Usually, do we say birth defect? Please, it's not the correct way to say it. It's not birth defect. We usually have in the brain, there's what you call malformations, cerebral malformations. Therefore, some malformations may occur in the brain of the child due to abnormal development. Therefore, all those malformations that occur may meconium aspiration, the child aspiring or inhaling the first poo-poo, his own first poo-poo. Therefore, may lead to this. Then we have talked about breast asphyxia. Then the child may have respiratory distress syndrome, which is likely going to cause CP. Then somebody will say, how? Usually what used to happen is the lungs of a child, unborn child, is usually filled with water when he is the womb. Then what happened is just few hours or hours to delivery. When the child is ready to come out, all the fluid in the chest and in the lungs will now be drained, such that the lung would become would be ready to receive atmospheric air, so that the child will breathe. Therefore, when the lung is not really ready, or there is some accumulation of fluid, or the lung is not fully patent and ready, the child is likely going to develop respiratory distress syndrome, may likely going to need special care, baby needs, and some emergency attention. Then pathophysiology of CP itself. They say CP results from permanent or static lesion of the cerebral cortex during its development. Therefore, one cardinal way of diagnosing CP is that the injury must occur when the child is in the womb. You can trace the origin of the injury when the child is in the womb, or immediately after birth, or up to 2 years. That is it. And the lesion must not be progressive. Then the second point, they say specific hypoxic event associated with immediate and irreversible cell death explain the etiology of cerebral palsy in less than 50%. Therefore, in less than 50%, you can trace that some people some hypoxic event occur. Therefore, when we are asking the mother what happened, she will tell you that she has been on labor for 2 days. The child has become tired. The child has become distressed. The child is ready to leave the womb. The air that actually, the water that fill the lung has already been drained, ready for the child to come out. And the child cannot breathe because it's inside the mother's womb. There is no atmospheric air. Then the child's brain will just be damaged. Then they said, it may be as a result of what? Breech presentation. The child is supposed to come cephalic with the head first, then the body will now come. Then if the child comes with the leg first, and they are busy trying to turn, and the child become hypoxic, is another thing. Or the child will come, probably he has aspired something that clogged the nose, then it's another thing. Therefore, there are so many things that will lead to this hypoxic event. Normally, we ask the mother, will say, yes, the child did not cry until the nose beat before the child start crying. What made the child not cry? Probably specific hypoxic event. Then fetal production of cytokines can damage neurons and vascular endothelial cells, contributing to intraventricular hemorrhage. What they are saying is that at some instances, it may not be as a result of the mother, but the fetus itself may produce some inflammatory cytokines that damage endothelial cells that lead to intraventricular hemorrhage, meaning that there is tendency the child will come up with diplegia or hemiplegia, not because of the hypertension in the mother. Yes, one of the predisposing factor for having hemiplegia in some children is as a result of what you call perinatal arterial ischemic stroke. The child will have perinatal arterial because of the high blood pressure in the mother. Therefore, but at times it may not be. It may be as a result of some of the hormones that the fetus produce that end up destroying the endothelial cells, contributing to within itself, contributed to intravascular ventricular hemorrhage. The unique metabolic demands of basal ganglia in the fetus at 38 to 40 weeks can result into dystonia. What they are saying here is that it may not be always that it is either jaundice that causes damage to basal ganglia. It may be due to when the child is about to be given birth to, around 38 to 40 weeks, or the child is prolonged in the womb after 38 weeks, there are some specific demands, probably of oxygen, that the basal ganglia needs, and the child in the womb cannot until it's outside the womb. Therefore, if the specific demands of basal ganglia are not met, of oxygen, of blood supply and nutrients, then it can become damaged even before the child comes out of the womb. Then it may be a factor. Then they said dyskinetic movement disorders occur after hyperbilirubinemia and basal ganglia injury. Yes. Therefore, whenever you see a child with dyskinesia means abnormal movement. The child is restless. A child with spasticity is always quiet. He has paucity of movement. He does not move until you move him, because spastic muscles are weak, and actually they look so strong because of co-contraction. But in dyskinesia, we call it dyskinetic CP types. These guys are having either choreoathetosis or athetosis. What you observe in these guys is that they are always in motion. When you keep them, the hand is moving, the leg is moving, then they said it's usually caused by hyperbilirubinemia. meaning that there is hyperbilirubin in the body. And then remember we said this unconjugated bilirubin can pass through blood-brain barrier and causes what? Kernicterus. Then we'll move to cerebral dysplasia. It's associated with what? Periventricular leukomalacia. Periventricular leukomalacia. What is this periventricular leukomalacia? We call it white matter lesion. In the brain, we have what you call the gray matter. In the spine, that is on the outside. In the middle of it, the brain is what you call the white matter. They are the ones that form the track, the spinal tract. They passes through what you call the internal capsule. Usually, when you have white matter lesion, it's around the ventricles. We call it periventricular lesion there. Then quadriplegia is essentially diffuse CNS lesion. Therefore, whenever we see a child with what we call it quadriplegia, where all the four legs and the trunk are affected, then is as a result of diffuse CNS lesion. Please, there is another one. At times when you see a child with the quadriplegia and serious cognitive impairment, at times these guys are having mixed CP. They may have both pyramidal lesion. They are called having mixed type of CP. They said hemiplegia is most common in babies born at term and is associated with single hemisphere injury in most cases. Yes, usually when there is single hemisphere, we understand this, but actually what used to cause it, it may be usually is as a result of either ischemia in the brain or is as a result of hemorrhage. Periventricular, what do you call it? Usually periventricular leukomalacia usually cause dysplasia. And then one predisposing factor for dysplasia is prematurity also. One predisposing factor for hemiplegia is perinatal arterial ischemic stroke. It may be as a result of, we said, the cytokines and other inflammatory markers that lead to hemorrhage within the brain that are produced by the fetus itself. Then we have loss of the sensory inhibitory input via reticulospinal tract and other systems may increase accessibility of alpha and gamma neuron producing what? Spasticity. But the most important thing we have to understand is that what usually causes spasticity is lack of inhibition of the what do you call it, primary allospiral and what do you call it, flower spray what do you call it, organs in the muscle spindle. Therefore, they are being controlled by what you call the gamma motor neuron. And the gamma motor neuron, actually, what controls that thing is the what do you call it, the cerebral cortex. It actually inhibits overexcitation of muscle spindles. When the cerebral cortex is damaged as a result of stroke or CP, then there is release of inhibition of the gamma motor neurons. Therefore, they become hyperactive and the muscle spindle become hyperactive and the muscle becomes spastic. Therefore, that is why this one is spelling loss of inhibitory input via reticulospinal tract. They are telling you that the inhibition that the brain does to prevent overactivity of the muscle spindle is via reticulospinal. Okay. Then we now have early signs of cerebral palsy. What are the signs that a child has cerebral palsy? Early hand dominance. The child may be having hemiplegia, but the child, what do you call it, has not reached the age of starting, standing and walking. You may not likely see it, but the child prefers to use one hand. The other hand is always by the side. Then it's a sign that something is wrong. Probably, if you look very well, the leg is also not as good as the other one. You see that sign when the child comes to crawl, then the child may not be able to crawl because one side is weak. Delayed motor milestone, like mostly that is what used to bring the mothers to the mothers of children to physiotherapy department. They are unable to have good neck control. They are unable to sit at the age of 6 months or so. They are unable to roll. Then the child will just stay where the mother keeps the child. Then it is then going to give the mother some concern. Then she comes to the department. Then we have persistent primitive reflexes. This is part of what we see as physiotherapists, and we always want to assess reflexes. If there is persistence of primitive reflexes, that inhibition, please, we have to understand that reflexes are what the child, a born child, interacts with in order for survival. Therefore, when anything comes close to the mouth, it's meant for eating. Therefore, the child will start sucking it. If the child is unable to suck, then there will be problem. Therefore, at times the handling, at times these reflexes are the ones, like for example, pain. Cry is a reflex telling you that something is wrong with the child. Cry is a reflex telling you that the child actually needs some food to be taken. Cry is a reflex that somebody holding the child is not actually the mother. Therefore, there are reflexes that children communicate with their environment with. But later, some of these reflexes will have to go in order for more advanced reflexes to come in. When these more advanced reflexes comes, and then a more advanced posture is to be assumed, like balance and equilibrium reaction, then all other reflexes will now go to allow for balance and equilibrium reaction so that the child will be able to walk. When reflexes refuse to go and they become obligated, is a sign of cerebral palsy. Then we have seizuring before the age of 6 months. Then the child legs crossing each other and does not want to separate. It's a sign that this guy is likely going to have CP. Then floppiness of stiffness. Yes, you have a child, even at the tender age of 2-3 months, you want to bath him and the child is becoming too stiff. Then it's a sign that spasticity has started setting in. Or floppiness, the child is becoming too soft. Anywhere you take the muscles are too soft, the joints are hypermobile, then it tells that it's hypotonic. CP is likely going to be a sign that the child is likely going to have CP. Then diagnosis of CP. Usually the diagnosis may require 3 to 4 things: clinical features of what you see, abnormal tone, all these ones, the reflexes and the rest. Then history taking, you now ask the mother. From what the mother tells you, it's likely that the child got CP from the womb, or during birth, or postnatally, or physical examination. What you examine the child will now tell you that this is likely going to be CP. Like, for example, in physical examination, you see the child with very small head, you know it's likely going to be microcephaly. Some of these things may tell you. Or neuroimaging. Some people will now say, okay, do cranial ultrasound, do MRI, do CT scan to see, probably you are going to see what do you call it, periventricular lecomalacia, or you are going to see an infarction, probably it's an ischemic stroke. Yes, but usually with very good clinical history taking, even the doctors referring patient to us, they don't usually, what do you call it? They don't usually order for neuroimaging. They know with this is just CP. That is all. At times, they do neuroimaging if they suspect intracranial space occupied lesion, so that they will be able to manage or order for surgery if it is cancer in the brain. Then prevention. What are the ways to prevent CP? The most important thing is for mothers to go for antenatal screening. Let her know her HIV status. Let her know her blood pressure status. Let her know her diabetes status. Let her know her weight and height and everything. Let her know if she has underlying condition that will predispose her child to danger. And then with time, as she is going, they will now keep assessing her for infection. They will keep assessing her for what do you call it? Not infection. The blood group. If she is rhesus negative, then it's another factor. They will assess her for what? Sensitivity, using indirect test. It's another thing. If she is sensitive, then the child is likely going to, she's likely going to be prescribed some medications like Rogam, so that sensitivity will go. Then we have antenatal clinic visits, and prophylactic antibiotics during pregnancy is very important. Antenatal magnesium sulfate before delivery.
The network is not really stable, sir.
Okay. Can you hear me now? Hello. Hello.
Yes, we can hear you, sir.
Yes, we can hear you.
Okay, then apart from the antenatal visit, that is very, very important for the mother to know her status. And if there is anything, then the appropriate action will be taken. Then the issue of this is generally based on research. Magnesium sulfate before delivery may prevent cerebral palsy that are being born in less than 30 weeks of gestation. Then we now have antenatal corticosteroids may decrease intracranial hemorrhage, and they said it's also neuroprotective. Therefore, these are also researches. Therefore, probably with time, we will see that our pregnant women will be given magnesium sulfate, corticosteroid treatment. But now this is based on research. They said mechanical ventilation of preterm babies. This is done whenever a baby is born preterm and he exhibits signs of what? Respiratory distress. The child cannot breathe on its own. Definitely they need what? Ventilation. Prophylactic campaign, metazaltine, prior to extubation, may effectively prevent cerebral palsy. Therefore, what they are saying is when the child, you now found the child is having some respiratory distress, he is preterm, you take the child to the special care baby unit, they intubate the child. They said for them to be extubated, they can prescribe prophylactic caffeine. They said if they dose that, it prevents cerebral palsy in most of these children. It's still research. Then prevention, they said for neonatal encephalopathy, remember we said there is encephalopathy or asphyxia, therapeutic hypothermia commences 6 hours of delivery by decreasing temperature by 2 degrees for 48 hours. They said it's neuroprotective. Please, I have read a lot about hypothermia. What they do is that they believe that when the temperature is high, metabolic activity increases in cranial muscles. Therefore, just like the way we used to say in physiotherapy, in our electrotherapy, that heating modalities are contraindicated in an ischemic tissue. When there is loss of blood supply due to tourniquet or anything, you don't apply a heating modality. The reason being that there will be increased metabolism. There will be need for more oxygen, need for more nutrients. And then if that cannot be provided because there is a lack of blood supply, then that will accelerate cell death. Therefore, but when you apply cold, then it reduces metabolic activity in tissues. Therefore, that is why they said for a child that is having some ischemia or encephalopathy, they said therapeutic hypothermia by reducing the temperature will reduce metabolism and it would reduce the demand for oxygen and nutrients by the brain. They said it's protective. It reduces cerebral palsy by 15%. Then they say prophylactic use of progesterone. That is what do you call it? Female hormone decreases early birth in women with previous birth complications. Therefore, they said this is also research-based. They said if a mother that has history of previous complication and early birth, meaning that preterm delivery, if she can be given prophylactic progesterone, may decrease the rate at which she gives child preterm. Then the prevention of preeclampsia is done by screening and administration of acetylsalicylic acid. What is acetylsalicylic acid? Mostly aspirin. Go here, but they said acetylsalicylic acid and aspirin. But as far as I'm concerned, aspirin is acetylsalicylic acid. Should be started before 16 weeks of gestation. And then, but usually here, when you are suspecting preeclampsia, a mother comes and the test is done. She is having toxemia, likely of toxemia because there is protein in the urine. Then plus some other factors. Then they said prophylactic acetylsalicylic acid will prevent what acetylsalicylic acid does is it prevents blood clotting. It prevents what do you call it? Coagulation of the blood. Though it also leads to what do you call it? It aggravates peptic ulcer for people that takes orally. Okay. Then neurological assessment for us, there is a scale. If you go online, you have the Hammersmith Infant Neurological Examination. It's a good one we use, but actually it's too big. It is too can I say the items are many that you cannot use them in the routine clinic, probably in research, but routine clinic only that you can take some items like movements, like tone or reflexes you can be taking, but it's very comprehensive, but the items are many. Then motor assessment in children with CP, gross motor function classification system. Here, we said it in our last 2 lectures that we don't use muscle power grading in children with CP. We don't say the biceps is having power of 3, triceps having power of 2, all these ones. What do? We have to grade all the muscles in the body for a quadriplegic patient. No, what we have a uniform way of communicating the gross motor ability. When we use gross motor function classification system, If I said gross motor function classification system 1, I mean that the child is ambulant. The child can walk without any help. The child can climb stairs without holding rein. The only limitation the child has is on higher level of functioning, like jumping, like hopping on one leg, like all this higher level of functioning that is required, tandem walking that requires a lot of balance, good balance is what is what you call it, missing. Or like walking for a long distance, it may be difficult, probably because the child may fatigue easily. This is like most of the children that fall into this category are hemiplegic type of CP. Then we now have the second for gross motor function classification system 2. They are the ones that are following these ones. Actually, they can walk without any support, but at what you call it, shorter distance, probably within the house. If they want to climb, they need the assistance of a rail or somebody holding their arms. This is gross motor function classification 2, but they can walk without support only for shorter distances, and climbing may require some little help. Then the gross motor function classification 3, they are children with CP that can walk, but with the help of a walking aid. Like any child that can crawl and hold onto the wall and walk, he has meet criteria for what? Gross motor function classification 3. Any child that you give a rollator or rolling walker that can walk with it, that is gross motor function classification 3. Any child that you use your hand and he holds onto your hand and he walks, that is gross motor function classification 3. Any child that you give wheelchair and he can use his 2 hands to operate the wheelchair on his own, that is gross motor function classification 3. But when you use gross motor function classification 4, that is where the child can only sit. He cannot move an inch on his own. Meaning that for a child that is, let's say, up to between 1 and 2 years, anyone that can crawl is like gross motor function classification 3, because he can leave one position to the other position, but only he cannot use his 2 legs to walk. Then it's 3. But anyone that can hold onto the wall and walk, he has reached 1, 2, 9, 3 now. Altogether. Yes. Anyone that can crawl can be 3. Anyone that can hold onto the wall and walk is also what? 3. Because he can live. But 4, he can use only power wheelchair, where somebody can only hold a jockey. Or somebody, a child that can only sit but cannot change position. Is at what? 4. He can sit but cannot change position. But you have good neck control, good back control, and he can stand, but you can never walk. You can ask him to stand, with help he can walk, but he can never take step. Therefore, any child that on his own, due to his own natural ability, cannot leave a place, even with walking aid, that is what? 4. Then the one that has no anti-gravity neck control, he cannot even sit on his own. The mother can only back him. That is 5. That is the poorest of all. But anyone that can sit, can roll and sit, but he cannot leave that particular position is at 4. The one that is being backed is at 5. Then we have now the comprehensive gross motor function measure. I think in our last 2 lectures, I have given descriptions of the gross motor function. Is the most respected instrument when it comes to the measurement of gross motor ability. This one for classification system is meant to just classify 1, 2, 3, or 5. But gross motor function measure is the one that we rate. We have gross motor function 66 and 88. We use it. We have PRECH assessment of general outcome, movement assessment of young children, ages and stages questionnaire. All these ones can be used to assess motor function. Then we now have reflexes. These are important. This is part of the repertoire of physiotherapy. We do assess reflexes as part of general assessment of the child. Motor reflex, and then here we have described its reflexes. We have stimulus and response, and the age at which it is integrated, meaning that you can see motor reflex, it is integrated 5 to 6 months, meaning that after 6 months, if you see motor reflex, meaning that the child is abnormal. We have flexor withdrawal, we have cross extensor, we have grasp reflex. We don't really have time to describe them, each one of them. We call moro a static reflex, flexor withdrawal, we have it, all the reflexes. Then we now have asymmetric tonic knot reflex, symmetric, all these ones are reflexes that if they become obligate, they refuse to go wrong. Like for example, asymmetric tonic knot reflex, become integrated 4 to 6 months. After 6 months, then it has to disappear. Then we now have estimation of CP prognosis based on postural reaction and primitive reflexes. Here we have it. Please, there are other prognosis indicators. I only use this one. There are other prognosis indicators. There are some prognosis indicators that will tell you that if a child is still having asymmetric tonic neck reflex up to 2 years of age, it's not likely going to work. A child that does not attain sitting ability up to 2 years of age is not likely going to work independently. All these ones are other prognostic indicators. But here they use another way of getting prognosis for the children. Here in the top upper part, we have some reflexes. We have asymmetric tonic neck reflex, symmetric tonic neck reflex, Moro, writing, and extensor thrust. What they mean here is, they said when a child is at least 12 months of age, score at least 1 point for the following primitive reflexes if they become obligate. What they mean is that when you assist asymmetric tonic neck reflex, they're supposed to leave the child by the age of 6 months. If it is there, you give 1 point for the child. If it is not there, you give 0. Meaning that giving 1 point is telling you that something is wrong. Giving 0 is the one with need. Therefore, if a child is having 2 reflexes that are present at the 12 months of age, meaning that the child has +2, which is not actually good, what is required in the upper part is the child to have 0 score. That is positive. That is good for the child. Then look at the second part, a score of 1 point for each of the following postural reactions if present, and a score of 0 if absent. In the other part, we want a score. In the lower part, we want a score. The upper part, we don't want a score. But for the lower part, we need a score. They are good postural reaction, like foot placement, parachute reaction. They said if we take these two, foot placement and parachute, for example, if they are positive, the child can place foot, the child has positive parachute reaction, then they mean that if we can give 1 point for that, if they are present, we give 0. Look at the scoring. They said score 1 point for each of the following postural reaction. If absent, please. If they are absent, you score 1. If they are 0, they are absent, you score 1. If they are present, you score 0. They score 1 point for each of the following postural reaction if they are absent, meaning that we need them. If they are absent, we score what? 1. If they are present, we need what? We score 0. In essence, 0 is required for the scoring. In both upper and lower part, we need 0. Anytime we score 1, meaning that something is wrong. In both upper and lower part, 0 is required. Therefore, for the upper part, if you said asymmetric tonic neck reflex, symmetric tonic neck reflex, if they are present, you score 1, meaning that something is wrong. Then for the lower part, if parachute reaction is absent, then we score 1. If it is present, we score 0, meaning we need parachute reaction to be present. If it is absent, we score what? 1. If it is present, we score 0. In the two stages, we need a score of what? 0 always. That is what is required. If the child is having 0 point in the 2, then it's good, meaning that he has good prognosis. Then if the child is having 1 point, meaning that either parachute is missing or asymmetric tonic neck reflex is present, then he has at least 1 point, meaning that is guarded, meaning that you should track the changes. The child is likely going to do good. But if the child is having 2 points and above, meaning that the child is likely going to have poor prognosis. That is what is required. Okay. Then we now have classification of cerebral palsy. We have 2 systems of classification of cerebral palsy. We have physiological classification and we have topographical classification of cerebral palsy. In physiological classification, we classify the child either having pyramidal or extrapyramidal CP, while in topographical classification, it is actually a classification of spastic cerebral palsy. Topographical classification is a classification of spastic type of cerebral palsy. Therefore, physiological, we have spastic, pyramidal, dyskinetic, extrapyramidal. Ataxic is extrapyramidal, and mixed is a symptom of both pyramidal and extrapyramidal. What do we mean by pyramidal? We mean that when when neurons that passes, or what you call the corticospinal tract that passes through the medullary pyramid become affected, then we have spastic type of cerebral palsy. Then when we have subcortical structures like lentiform nucleus, coded nucleus become affected, they are basal ganglia nucleus, then the child is likely going to have what? Extrapyramidal symptom, and that is extrapyramidal. Then ataxic is usually affectation of what? Cerebellum, which is also extrapyramidal. That is why we have physiological classification can be pyramidal or extrapyramidal or mixed. Therefore, when you have a child with mixed CP, is likely going to be quadriplegic and is likely going to have severe mental retardation, then that is a mixed type. We have both pyramidal and extrapyramidal. And we said in mixed type of CP, usually you have in quadriplegic, usually you have diffuse cerebral injury. Then, but remember we said topographical classification is the classification mainly of what? Spastic type of CP. Then let's move to the topographical classification. In the topographical classification, we have monoplegia, diplegia, triplegia, quadriplegia, and double hemiplegia. Then we now have now I brought, I added some classification, definition of cerebral, spasticity. We say spasticity prevents selective motor control and impairs effective functional use of the limb. What we are saying here is this is a negative consequence of spasticity. It prevents selective motor control. Like when we say selective motor control, if I said, can you bend your hand? You would bend your hand at the elbow, that is biceps cord, or can you stretch your arm, then the triceps will now come into action. Therefore, if there is core contraction, the child will not be able to either bend or stretch the arms due to the hyperactivity of both agonist and antagonist muscle. That is what spasticity causes. Then we now have, we said spasticity is a velocity dependent resistance to passive stretch by the muscles. In essence, they are telling us, we physiotherapists, when we are moving a child with spasticity, we said it's velocity dependent. We should move the child slowly. That is how we are going to inhibit spasticity. But when you move faster, the spasticity will become marked, and at times what you call muscle tear in the child. It causes serious pain and inflammation. It is characterized by excessive stiffness in the muscle when the child attempts to move to maintain posture against gravity. They say spasticity can vary according to the child's state of alertness and emotion. Therefore, when the child is happy, the spasticity is going to go down. When the child is sleeping, the spasticity goes down. But when the child is under pain, the spasticity becomes what? More stiff and under, and when the child is crying. Then they say hemiplegia. Now, with hemiplegia, one side of the body is affected, upper limb more affected than the lower limb. Yes, this is very common even in the elderly. Therefore, when you have somebody with hemiplegia, you now see that the upper limb is likely going to be more affected than the lower limb. But actually, it depends on the side of the brain that is affected. Please, if it is mainly the middle, the area supplied by the middle cerebral artery that is damaged, then you are likely going to have upper limb more affected than lower limb. But if you have anterior cerebral artery damage, meaning that it's usually on the frontal part, usually the lower limb is likely going to be more affected than the upper limb. Go and read about it. Then we now have cerebral diplegia. Here in diplegia, all the whole four limbs are affected, but lower limbs are more affected than the upper limb. In cerebral diplegia, a child with cerebral diplegia mostly can walk using walking frame. The hands are weak, but they actually can be active enough to lift something. But the lower limbs are the ones that are more affected. Then in quadriplegia, there is total body involvement. All the limbs and trunk are affected. I will say it is caused by diffuse cerebral damage. Then we now have double hemiplegia. Here, all the limbs are affected, but upper limbs are more affected than the lower limbs. But we used to add something, we said asymmetrically. Asymmetrically in the sense that the two hands are affected than the two legs, But usually what happens is one hand is stronger than the other one and one leg is stronger than the other one. You can easily say that one side is definitely stronger than what? The other side. It's hemiplegia, but one side it tends to be what? Less weak than the other side. While in what do you call it? In cerebral dysplasia, the two legs are affected equally than the two hands. You will definitely see that the condition is the one, purely the legs are the ones that are affected more than the, but in this one, though the two legs are less affected than the upper leg, you can easily see that one side is actually stronger than the other side. That is double hemiplegia. Then triplegia, one limb is affected. In triplegia, somebody will ask, in triplegia, what then happens? We have two legs and two hands. But is it that one leg is the one that is not affected or one hand that is affected, or the interplegia, only one limb is not what? Affected. Three legs are affected and one limb is not affected. Okay, let's go back to let's go back to monoplegia. We did not talk about monoplegia here. Please let me start with monoplegia. Actually, in monoplegia, what used to happen is the hands are usually more affected than the leg. Researchers have shown that most children with hemiplegia, they are mildest form of hemiplegia. What used to happen is that because in hemiplegia, the hands are more affected than the leg. The leg will now become almost not affected. You now see as if there is nothing happened to the leg. The hand will now be a little bit weak. Then when they say is what? Monoplegia. But usually it's the mildest form of what? Hemiplegia. Then it's the same thing that happens in triplegia. Somebody is likely going to have double hemiplegia. But in the double hemiplegia, what happens is one side that is more affected will show. The one leg and the one hand are very, very affected. But in the other side, it is so mild that only the leg shows what? Affectation. The hand is what? Not affected. It's a double hemiplegia, but the other side that is less affected, only the leg show. The hand did not show. Usually, that is why we call paraplegia. Yes. If we really understand this, then dyskinetic types of CP. What is a dyskinetic type of CP? A CP, what we mean by dyskinetic, we mean by hyperkinetic. They are always in motion. We used to say the difference between spasticity and dyskinesia is two. In spasticity, what do you call it? How do you say it? In dystonia and hyperkinetic, you see. What do you see? You see movements. While in spasticity, you test. What you usually test is you see hyperactivity, there is positive movement. But in dyskinesia, your eyes will just tell you. Without even touching the child, you see the child busy moving the hand, busy moving the leg, you see with yourself. But in spasticity, what you just you have to test for you to see the spasticity. But in the other one, you see with your eyes. It refers to increase in muscular activity that can result in excessive abnormal movement, excessive normal movement, or combination of two. Look at this guy. They said it refers to increase in what? Muscle activity that can result in excessive what? Abnormal movement. It can also result in excessive what? Normal movement or combination. In essence, a child with dyskinetic CP may be doing something that is okay, but he may be overdoing it. May be doing something that is what? Not okay. Yes, or maybe combination of both normal and abnormal movement. It is characterized by abnormalities of tone and various movement combination, dystonia, atetosis, and chorea. Okay, now let's see what is dystonia. What differentiates between dystonia, chorea, and atetosis? Okay, dystonia is a sustained intermittent muscle contraction causing repetitive twisting or what? Repetitive or twisting movement. Okay, what do we mean? Look at it. I have highlighted what we mean in dystonia. The most important thing is sustain. When a child moves the hand, when he reaches the end of range, it will not come back. It will stay for some time before it comes back. Somebody twisting the leg as if he is a snake, and the leg will stay for some time, then he comes back. That is dystonia. Somebody moving hand and leg, but maintaining movement for some time, then coming back. That is sustained movement. That is dystonia. Then what is atetosis? Uncontrolled, slow rhythm movement without recognizing fragment that prevents maintenance of stable posture. Then here, the most important thing in atetosis is without fragment. Then somebody will say, what is fragment? A lack of fragment is what makes it snake-like movement. You can never see. Let me give you an example of fragment. When you bend your hand into flexion, when you reach the end of flexion, you now move the hand again into extension. By the time you reach end of flexion, that is fragment. By the time you reach end of extension, it's another fragment. But in dystonia, it's not like that. The hand movement is like snake, and you can never see any fragment. You can never see where the hand stops and it continues. No, it is just a movement like snake and no fragment. That is atetosis. Then chorea. Then I think just give me 1 minute if I can play. Though I don't have the video, I think I missed the video. You can see in chorea is an ongoing random movement. It's an ongoing random movement. If you can tap your hand on top of your table 10 times, and you keep tapping the hand all together with fragments, that is chorea. In chorea, in children, is like the hand will keep moving up and down, up and down, up and down, then it will not rest. Move up and down, it will rest. The leg will move up and down, it will rest. That is chorea for you. It's an ongoing, random appearing movement. It is all like dystonia. Dystonia is more close to atetosis because in dystonia you move, but the only thing is that when the cell reaches the end of range, it will stop. There is what you call sustenance of movement before it comes back. But the movement is twisting also. In atetosis, yes, the movement is uncontrolled, slow rhythm movement, just like snake moving, but there is no fragment at all. And there is no sustained posture. But in chorea, there is fragment, but there is random movement. Just as if you are tapping your hand on the table. The leg will just be tapping, the hands will just be tapping. That is chorea. An ongoing random appearance sequence of one or more discrete involuntary movement. Children with chorea present in constant motion. That is chorea for you. Okay? Then we now have the differences. We have said it. Atetosis is distinguished from dystonia by lack of sustained postures. From chorea by lack of what? Identifying fragment. Suchan in dystonia, in atetosis, there is no fragment. It's as if you are a snake moving. No fragment and no sustained posture. In chorea is distinguishable from dystonia due to apparently random, unpredictable movement. The movement is random, while the other one movement is like that of dystonia, only that there is sustained posture. Okay, then ataxic CP. Ataxia is characterized by shaky movement that affects the person's coordination and balance. One good thing with ataxic CP is that most of the children with ataxic CP can walk. The only thing is like they walk like drunkards. They walk and fall down. I did research with a child that has ataxic CP. He walks and fall down, but he actually can walk. It occurs in 6% of the children with CP. Half of them due to autosomal recessive cerebellar disorder. Half of them due to lesion in the cerebellum. They may present with hypotonia. Yes, this is one of the important things that accompanies as physical assessment. Usually, for a child with hypotonia, something should come to the mind of a physiotherapist. When somebody is having hypotonia, it's either the child is having Down syndrome, or is likely going to have hypotonic CP, and that hypotonic CP may end up becoming ataxic CP. Children with hypotonia and loss of coordination are likely going to become having ataxic CP. Some children with hypotonia are likely going to become are likely having Down syndrome. Then the mixed CP type. What are mixed CP types? The CP type where you have both types in the same child, where you have diffuse brain damage. More than one type is apparent. Usually all types are dominant. Then we have mixed type of CP. In this type of CP, the child does not even recognize the mother. The child will be managed for life. He cannot, hardly will they attend. Probably the highest is, some of them they are even visually impaired. They don't recognize the mother. They may not take something, orally. They are usually very stiff also. These are mixed motor type. They carry very poor prognosis. Okay, foot deformities in children with CP. We are moving gradually. We have pes equinox. We see pes equinox mostly in children with CP, with what? Hemiplegic type of CP. They walk on toes. Therefore, now, remember when we are discussing this as a pediatric physiotherapist, when a child comes to your clinic and is walking on toes, what are the likely causes of walking on toes in the child in a pediatric environment? One, maybe TA tightness, maybe as a result of either dynamic or static TA tightness, maybe as a result of Duchenne muscular dystrophy that we discussed in previous lectures. Duchenne muscular dystrophy causes what? Walking on toes. Another one, we discuss it in a child with osteonecrosis, the calf-Pattis disease. Somebody is likely going to, the child is likely going to walk on toes. Then the child with hemiplegic CP is also likely going to walk on toes. You have to ascertain which one is which one. Then we have pes varus, the child walking on the lateral side of the leg. Yes, in our house, some children at times when they match something, they don't like to match, like shit or anything. They'll be walking on the side of their toes. Is that also? Raising the big toe. That is a pes varus. Then pes valgus, where the whole medial longitudinal arc of the leg goes down in form of let's say, flat foot, but this one is more grievous than flat foot. What it does is all the medial longitudinal arc will come down and protrude. That is pes valgus, and it's very common in children with cerebral dysplasia. Okay, pes equinox. We say pes equinox is ankle plantar flexion during gait. Ankle plantar flexion during gait, meaning that the child walks on the metatarsals. Due to gastrocnemius on soleus plus spasticity. Dynamic equinox. There are two types. We have what we call the static equinox, and we have what we call the dynamic equinox. Dynamic equinox, we said, occurs only during secondary to gastrocnemius or soleus spasticity, meaning that when you apply gentle passive stretching, it will give way. Meaning that a child with dynamic equinox is a very good candidate for a particular orthosis we are going to look at. We call it hinge type orthosis. It does not allow plantar flexion, but it allows dorsiflexion. It's a very good candidate for for this. Then we now have static equinox occurring due to shortening of gastrocnemius and soleus muscles. This is what we see in the therapy department. Usually, when the child has what we call tight TA tightness, we have static occur due to shortening of gastrocnemius and soleus muscles, TA tightness. Usually, when you see it, the child will definitely go for serial casting, or the child will go for surgery. If not, little passive stretching may not do. The child with pes equinox bears weight on the metatarsals. Okay, this is pes equinox. Usually, children with hemiplegic CP, if they are not managed very well, they are likely going to walk on toes, which is pes equinox. Then we have pes varus. We said pes varus is working on the lateral aspect of the foot. It's characterized by increased inversion and exaggerated weight bearing on the lateral aspect of the foot. Then it is due to tibialis anterior and tibialis posterior and triceps surae spasticity. What is triceps surae? Triceps surae is gastrocnemius, soleus, and plantaris. The ones that used to help you walk on toes, they are the triceps surae. Anterior tibialis is the one that helps you to dorsiflex the leg. It's the one that becomes weak when we have injection palsy. Tibialis anterior spasticity causes hand-foot varus. Tibialis, anterior causes midfoot varus. Pes equinox usually accompanies pes varus. Pure varus is relatively rare. And I said it last year that actually I saw pes varus. I managed a child with pes varus when I was doing my research. Yes, I was recruiting ambulant children with CP. Then a child came with a hemiplegic CP, and I saw her with pes varus, raising the lateral aspect of the foot. It's tibialis anterior spasticity. Therefore, the whole management will now be that you reduce spasticity in tibialis anterior, probably a little massage, sustained passive stretching, and then vigorous exercises. Because whenever the child is able to exercise and is able to get control of the limb, then the spasticity goes down. One way of reducing spasticity, which we are going to discuss in the management of spasticity, spasticity will take over the muscle. The muscle are weak. That is one negative aspect of spasticity. The muscle are weak, but the spastic muscle will look as if they are strong. Therefore, when you manage them by reducing the spasticity and you do a lot of vigorous exercises, when the child gets control of the limb, the spasticity is going to go down. Then we have this is space varus. Observe the right leg, the leg facing you on your left side, the right leg. The front aspect of the foot is saying is of overactivity of the dorsiflexor muscle, we call what? Tibialis anterior. Okay. Then, oh, I did not put pes valgus. Okay, probably as we are going to see pes valgus. Braces in rehabilitation. Here we actually concentrate on ankle foot orthosis. There are so many braces in rehabilitation. We have knee, hip, ankle foot orthosis. We have supramalleolar orthosis. We have what do you call it? So many of them. But the most important thing is braces in pediatric rehabilitation. We have so many of them. We are going to discuss them and the indication for each one of them. We said AFO, ankle foot orthosis, is the basic orthosis prescribed for children with CP. It helps to keep the foot plantigrade. What do we mean by plantigrade? We mean, look at this picture. The other leg is plantigrade. The normal leg is plantigrade. The child is able to put the foot on ground like this normally. That is plantigrade. They said it provides stable base of support in stance phase. Therefore, when a child is walking on toes, he does not have stable base. But when you apply something for him, like hinge AFO, and he puts the two legs plantigrade, it gives him more support than the other one. It prevents foot drop in swing phase. Yes, there are some instances where you see children walking with foot drop due to one reason or the other, or due to damage to a particular nerve, common peroneal nerve. You can use ankle foot orthosis to prevent foot drop. It prevents contracture when used at what? Night splint. Yes, for you to be managing, instead of coming to manage severe TA tightness, severe spasticity, it's better you use ankle foot orthosis as night splint. Therefore, when the child comes and you know definitely this child is likely going to develop this, most especially in your initial assessment after 3 months, when the child comes, you now see that the child is spastic. Why not get to the places where the child is likely going to have contracture or tightness, then apply ankle foot orthosis. Let it be used as night splint. That will help the child overcome spasticity and prevent prevent contraction. Then we just say we should apply caution. It is better to use some AFO per time in most individuals. Yes, this is applied to both AFO use and serial casting. We are going to discuss this. Yes, when you apply rigid AFO, in physiotherapy department, we are used to applying POP in somebody's leg. We want to stretch the TA. Yes, we apply POP, but we allow the POP to stay for 5 months or 1 month. When the child comes, the TA is being stretched, but the dorsiflexor muscles have become weak because they are not active. Because you apply something that make them inactive, you now have to incorporate vigorous exercise in order to strengthen them. Therefore, then they said some may cause sensory deprivation and muscle atrophy if used continuously. Yes, most especially rigid AFO. Therefore, sensory deprivation, you have applied something on the leg. If it is not fully padded, then somebody will lose sensation and then atrophy may likely set in. Therefore, we ask if somebody is using, most especially rigid AFO, that does not allow ankle motion, that does not allow any motion in the limb. You are only using it for support or to prevent contracture. Then the most important thing is we use it sparingly, or we change it after some time. Apply it after 2-3 days, remove it, allow for some movement in the leg, then reapply it again. Then we have types of ankle foot orthosis. Therefore, we have what you call the solid AFOs, or what you call the rigid AFOs. Most of the AFOs we use here, because we use them to provide support, they are solid AFOs. We mean AFOs that are so strong that they don't have, that are not malleable. Example, we have posterior leaf spring, we have gout reaction AFO, anti-recurvatum AFO, hinge AFO, hinge grapho, and hinge anti-recurvatum AFO. Solid AFO. What are the advantages of using solid AFO? What is the advantage of using it? It allows no ankle motion. Therefore, when you are stretching, you stretch a particular group of muscle, just like your what do you call it? Cock-up splint. Cock-up splint is not an AFO. It's just a splint, but it does not allow motion. When you apply cock-up splint, shikena is going to stretch, even if it is our flexion contraction of the hand, of the flexor muscles in the hand, then it stretches it. It does not allow motion. That is one of the advantage. If it is what do you call it, stretching, they are very good in that. It covers back of the leg and extends from below the what do you call it, fibular head to metatarsal head, which you are going to see. It covers below, immediately after your knee joint, from the fibular head up to the metatarsal head, meaning that it's one like the way you used to wear what do you call it, rain boot. Then it provides control of valgus and varus deformity. Therefore, any leg that has valgus or varus deformity, when you apply it, it is good. It also prevents contracture. We have said it. Provide ankle stability in standing frame. Yes, there are some, for some children, that they don't really have good, what do you call it, their leg will not have good contact with the ground. They are either having varus or valgus deformity. Then when you apply rigid or solid AFO, it helps to provide stable base for them to stand. It's beneficial for quadriplegic and diaplegic for control of what? Pes valgus. Therefore, when a child is having pes valgus, you can apply it, most especially small children. If it is a very big child that has pes valgus, then we use what you call anti-recurvatum AFO, what do you call it? Ground reaction ankle foot orthosis. But if it is a small child, you can put what? Solid or rigid AFO. It would limit or reduce the pes valgus. Okay, this is the picture of rigid AFO. You apply it the way you used to apply, what do you call it? You put on your shoe, you enter it into your, then you support it. But you remember, it has one disadvantage. Since it has no ankle joint, it does not allow ankle motion. It's better you apply it in the night, such that it will do everything you want in the night. In the morning, the child can be doing some other things. Okay, then we have posterior leaf spring. It's a form of rigid AFO, but it is made a bit flexible. It is a rigid AFO that is trimmed progressively posterolaterally and posteriormedially at the supramalleolar area. This side, if you can see my cursor, Hafiz, can you see my cursor? Yes. This is the supramalleolar area just above the malleolus. What happened is this, it is a rigid AFO, but is trimmed, just like this rigid AFO. If you turn this rigid AFO on the lateral, you see something like this. But this side is being trimmed. They trim it, they cut it. Then the other side, they cut it, such that the back of it will just become a little bit flexible. What did they use it for? It is used for children with just mild equinox. Provides stability at the ankle, allows passive ankle dorsiflexion during stance phase. It is an ideal choice for children with mild equinox and foot drop. Therefore, in Western countries, they don't use the anti-foot drop device we use in Nigeria. You know, in Nigeria, we use anti-foot drop device that you ask the child to bring his shoes. Go. Then we now put something in the leg. We now put one strap that goes from the knee joint to the foot. That is anti-foot drop device. There they use what you call posterior leaf spring. They insert it inside the shoes. The child keeps walking. What the spring does is that when the child does not have problem with dorsiflexion. He only has problem with what? And he does not have problem with plantar flexion. He has only one problem with dorsiflexion. Therefore, when he dorsiflex the ankle, look at the something. When he dorsiflex it, what happens is the posterior leaf spring will be deformed. It will go, the angle will increase. When he lifts the leg as he is going, the other lower part will now bring the foot up. Therefore, it does prevent foot drop. They use it for foot drop in Western countries. Therefore, if you are able to manage a child, if you don't have anti-foot drop device or places where they will do anti-foot drop device for you, this is a very good anti-foot drop device for you. Then for children with mild equinox, for children that walks on toes but mildly, then you can use it. It also helps to correct mild equinox deformity. But they said, do not use in patient with crouch gait or pes valgus. It is useless. Crouch gait can never be corrected with something so soft like this one. It has to be corrected with something so rigid. We need rigid AFO. to correct it, but this is soft. It's a form of rigid afro, but it has been trimmed. Therefore, it's not as strong as the rigid afro. Then this one, ground reaction ankle foot orthosis, is the one you use if you are, managing a child with cerebral dysplasia. In a child with cerebral dysplasia, what happens is that the child walks, but with the hips, the knees, and the ankle bent. If I ask somebody to bend as if he's going to jump up very well, normally you bend down with your knee bent, your hip bent, your knee bent, and your ankle bent. That is how children with cerebral dysplasia walk. Then the best way to manage them is to use ground reaction ankle foot orthosis. Then I want you to observe there is difference between ground reaction ankle foot orthosis and the normal rigid afro. Observe this rigid afro. When the leg is coming inside, the space where the leg enters is in front. You can see it. The space where the leg enters is in front. The support is coming from behind. Then observe in ground reaction ankle foot orthosis. The leg enter from behind. You can see it. And the support is in front. And then why do we have this one? 1 minute, please. Just give me 1 minute. Let me answer.
So that the knee will not give way.
Okay, I am back. Okay, we are discussing grapho. Usually, do we know knee buckling? The knee usually does not stand straight. It buckles down. The hip go down, and the ankle joint is also flexed. That is the typical posture of a child with with cerebral dysplasia. Then, how do we manage it using this one? There was a time we are managing patients. Somebody asked me, and I said for advice, and I said he should use grapho. They use grapho, but they have little problem using grapho. What is this problem? A child, this grapho, what it does is look at the upper part. Look at where my cursor is. This is where this part is wrapped around the shin area, just immediately below the knee joint. What it does is it pushes the knee joint back such that the child can stand straight. But how do you now use this thing successfully? Two things are required. Without doing two things, you are not likely going to use grapho successfully in children with cerebral diplegia. Number one, quadriceps are weak. This can only provide support. Then the quadriceps must be strengthened. Number two, hamstrings are short, usually due to the fact that since they have been adopting that position for long, the hamstrings are not being lengthened. You either use serial casting to lengthen the quadriceps, or they do surgery to lengthen the quadriceps, or because I have used also sustained passive stretches for the quadriceps, it was really tedious and difficult. Therefore, it's better use serial casting to stretch the quadriceps and the hamstrings. You have to work seriously on the quadriceps and on the hamstrings. When the hamstrings are able to lengthen, when you apply this, the child is going to stand. Another big problem with this thing is that since the posture requires that the hips, initially the hips are flexed, the most important thing, you must ensure that the hips are fully extended. When the child is actually having compromise in the hip extension, you have to work on it. Work on hip extension, lengthen the hamstrings, and then strengthen the quadriceps. Then the child is going to do successfully with ground reaction ankle foot orthosis. Okay, this is the description of the grapho. They say it's used in patients with quadriceps weakness or crouch gait. Therefore, whenever you have a patient with quadriceps weakness, and then you can use it on him, or he has crouch gait, that gait that I explained to you of somebody walking, hips flex, knee flex, and ankle flex, and he's walking like this, like an old elderly person, that is crouch gait. It is an excellent brace for patients with weak plantar flexors. A rigid grapho is used with good foot with foot alignment that is poor, and hinge grapho is used when the foot alignment is satisfactory. Actually, the pes valgus is where we have the foot alignment. In pes valgus, where the pes valgus is much, you apply the rigid one, then it can support it. Where the foot alignment is very good, you can apply the hinge one. The hinge one is the one that has joints in it. We said, note, children with static or dynamic knee flexion contracture do not tolerate what? Grapho. If somebody is having knee flexion contracture, or somebody is having a tight hamstrings, they may not be able to stand, because this is to help them stand. Then the hamstrings are tight, then they cannot stand. Surgically release the knee flexion contracture before prescribing what? Grapho, or you do serial casting. Okay, now you may have children that are weak, most especially those that are having hypotonic CP. They may be walking, but they may, instead of the knee to buckle forward, they may be buckling what? Backward. That is anti-recurvatum AFO. That is the use of anti-recurvatum AFO. It's a special AFO that is molded in slight dorsiflexion. Look at this guy. Please, let's go back. Can you see the angle, the joint of this one? It's molded in slight what? Plantar flexion. You can see it. Can you see this one? Look at the angle here. You can see it is molded in slight what? Plantar flexion. It's not at 90 degrees. It is at almost 110 degrees. Is that also? This is, and the reason being that they are pushing the tibia back so that the child will stand. That is the reason. They have to push the tibia back. But here, in anti-recurvatum AFO, they are pushing the tibia forward. It is loaded in what? Slight dorsiflexion, such that the tibia will not go backward into hyper what? Extension. They are pushing it slightly forward. The heel is built up to push the tibia forward to prevent hyperextension during stance phase. For the treatment of genu recurvatum in hemiplegic or diplegic children, anti-recurvatum may be solid or hinged. They are telling you, when we meet solid, things like this are what we call what? Solid. Things like this are what we call solid, no joint. Things like the rigid AFO, they are the ones we call solid, no joint. Then we now move to what? Hinge AFO. Hinge AFO. We mean hinge AFO. Please, let me give you example. Now, observe this. This is what we call hinge AFO. Observe this. In the hinge AFO, look at the joint here. There is a joint here. Observe the joint. The joint is not at 90 degrees. If you draw a line that goes up, this is 90 degrees. Go. The line that goes up, following my cursor. Look at my cursor. If you draw a line that goes up, this is 90 degrees, meaning that this is at a slight dorsiflexion. That also, then you can mold an orthosis like this or mold it more forward. Then when you put it more forward, meaning that the right side area here, when it goes forward like this, then it will now become what? Anti-recurvatum afford. Meaning that you can always modify hinge afford to become what? Anti-recurvatum afford. When the upper part of it here is what? Push forward. Then it will now become anti-recurvatum afford. Now, hinge afford. Hinge afford has a mechanical ankle joint, preventing plantar flexion and allowing full dorsiflexion. Now, if I should ask ourselves, this hinge afford, which type of patients will be useful, or which type of patient will benefit from hinge afford? The most important, when you have a patient that walk on toes, especially dynamic equinox of the leg, somebody working on toes, somebody working on what do you call it? Duchenne muscular dystrophy that is not very heavy enough, it can benefit from this because they are into plantar flexion. These are for prevent plantar flexion. It only allows the flexion. Observe, there is a stop here. Hafiz, can you see the stop? There is a stop. This side can only go up like this, but it can never go down. It can only go up, but it can never come down. Because of what? This particular stop here. Therefore, for somebody who's having dorsiflexion problem, he can only dorsiflex, but cannot what? Plantar flex. Then this is for the child that can plantar flex, only works on toes, then this is a very good afford for this child. Child working on toes, fix this on him, he can only dorsiflex, but not what? Plantar flex. But remember, we said don't use it every day. After 1 or 2 days, you remove it, you apply, the child works so that he, exercise the plantar flexors. Okay, they said it allows dorsiflexion in stance phase and provide no monomal gait. It makes it easier to walk on even surface and climb stairs. Because of the dorsiflexion, a child can climb stairs using it. It is the best afford for most ambulatory children. Most children that can walk with mild pace valgus, with mild pace varus, they can all work with it satisfactorily. Then look at the last sentence. Look at the last sentence here. I am turning it into red. You can see they said we should adjust the plantar flexion to 3 to 7 degrees of what? Dorsiflexion. We should move it further to control knee hyperextension or genu recurvatum, meaning that we should push it further by 3 degrees or 7 degrees. What it does is it is going to press on what? The back of the knee joint, such that the child that is doing hyperextension in the stance phase will now not do it. Always modify this to become what? Anti-recurvatum afford. Okay, last time we said it. Please, this is not part of the repertoire of physiotherapy. Measuring cognitive function in children with CP. For adults, we used to measure it. For children with CP, actually, people in psychiatry and clinical psychology are the ones doing it. And most of these tests that we do, the tests, actually, you have to pay for them. Usually, they are online. You pay for the money. They give you the kit and you do it. We have Raven's, IQ tests. We have, they said, Raven's colored progressive matrices designed for children. This Raven standard, all these ones. You go and read about it. And we have the Raytas trial making test. We have Ray complex figure tag text, Wechsler intelligence scale. Please, this Wechsler scale is used extensively. It's used extensively in rehabilitation, most especially in pediatric rehabilitation. I think one of these days we are going to get these Wechsler scales. They come in the way you used to get your tens inside a container. Usually they come inside a container like this, a very big container and a bag. They come with a lot of things inside, with instruction. This is what we call the Wechsler scale for children. You don't use it. It's not like a pen and paper. The way you used to assess, let's say the way you used to assess back balance scale to put your score. It's not like that. They have items, battery of items with some with some items inside that you use. It's like a direct measurement of intelligence of children. Therefore, one day we are going to have the Wechsler scales by God's grace to assess intelligence. Then we now have other scales that we use. We have the Bailey scale of infant development. You have to buy peer body picture, vocabulary test, yes, cognitive drug research battery. All this one, anyone you hear battery, meaning that they are form of tests that you do this one, you do the other one, but they are not in form of paper and pen, just like the way we used to do assessment using paper and pen. All things that involves pediatrics, you have to pay money. Then we have evidence-based management. Please, this evidence-based management, we are discussing mostly for children that are ambulant. Evidence-based management for children that are what? Ambulant. The children with good trunk control. The second lecture is going to discuss on what we normally see predominantly in our clinic. Children without head control, children without neck control, children that cannot sit. How do we mobilize them to sit? In the next lecture, that is what we are going to discuss. When you see treadmill training, it's just like the children I use for my PhD research. They are ambulant children. You can subject them to any form of treatment, and you will see response. Therefore, treadmill training, we have systematic review by Juan et al. Suggests that treadmill training was effective for gait. It improves limb speed and improves limb support, but not improve cadence and step length. This is research. Novak et al. Also examined 3 systematic reviews. I reported that treadmill training, with or without body weight support, improved walking speed, endurance, and gross motor function. Therefore, the gross motor function here, they are talking about what? Walking, running, and jumping. Therefore, whenever you hear treadmill training, the gross motor function is walking, running, and jumping, because we have other lower level gross motor function measures. Here we have neurodevelopmental therapy, NDT, which majorly form 80% of what we are going to discuss in our next lecture. They said a systematic review by Zano et al. Found no difference between NDT and conventional therapy on gross motor function. They concluded that that the effect of NDT for children with CP is still uncertain. But there is, up till tomorrow, there is no treatment for children with severe motor disabilities other than NDT. NDT is still the gold standard for children with severe motor disabilities. Then we have hippotherapy, therapeutic horse riding, systematic review and meta-analysis by Gundus et al. Reported improvement in gross motor function, balance recovery, and improved muscles, spasticity in children with CP. Therefore, but usually, if we look at most of the researches that utilize hippotherapy, they are mainly for children that have poor, postural control. Children that have poor postural control, it helps them to improve their posture, it helps them to improve their sitting, it helps them to improve sitting endurance. Therefore, usually they are the most important, beneficiaries of hippotherapy. The Novak et al. 2020 also found conflicting evidence of hippotherapy relative to gross motor function, but reported some positive effect on trunk position and arm function in GMFCS 1 to 4. Yes, usually hippotherapy is meant for children with gross motor sitting problems that have spasticity in the trunk musculature, poor trunk control, and then poor ability to use hand in sitting. Usually hippotherapy plays a good role in that regard. Then we now have evidence-based management, massage. Manual therapies, including massage, help to reduce constipation. Massage also appear to help reduce pain. Therefore, for most children with CP that we found that they have pain, research have shown that massage reduces pain. Massage also reduces what? Constipation in children with CP. Therefore, somebody will say, how? Usually, the cause of constipation in most children is inactivity. Therefore, when you use any form of mobility, you mobilize the patient, you massage the patient. At times, it gives them relief. Probably it improves their gastric motility. But actually, the mechanism may not be known to us. Probably there should be research to find the mechanism. Then the next evidence-based management, a systematic review conducted in 2023 found that neuromuscular electrical stimulation effectively improved hand function. muscle strength, and decreases spasticity in children with CP. Therefore, the issue is also is part of the management of spasticity, what do you call it, neuromuscular electrical stimulation is part of what you are going to cover in the management of spasticity. Researchers have shown that it may reduce spasticity, but which type of spasticity? Please, it's not generalized spasticity. It is what we call focal or local spasticity. Spasticity of only, let's say, dorsiflexor muscles. Spasticity of only plantar flexor muscles. Isolated spasticity problem, not general spasticity. That is what it means. Therefore, it can improve muscle strength. We have been doing that because children with CP that develop weakness of some muscle groups, you can use electrical stimulation to improve muscle strength. Then neuromuscular electrical stimulation in combination with traditional physiotherapy, sensorimotor training, and task-oriented training, constant induced movement therapy, dynamic bracing, and conventional robotic therapy resulted in significant functional scores, muscle strength, and upper limb, of the upper limb, and spasticity of the, the spasticity of the upper limb compared to this therapy alone. What they mean is that when you provide treadmill training together with neuromuscular electrical stimulation, when you do task-oriented training together with electrical stimulation, when you do your strength training together with electrical stimulation, when you do your constant induced movement therapy together with electrical stimulation, they said it's better than doing those ones alone. Therefore, that is a systematic review. But the most important thing we should note is that most of the therapists here, they are usually more of for children that are likely ambulant or that have shown sign of improvement. When you are dealing with children with poor head control, poor neck control, another approach comes into hand. Therefore, we thank you for listening. We are going to the next, the next lecture after we come back from break. Let me take some 20 minutes break. Thank you very much for listening.
Thank you very much, sir. You're highly welcome.
Thank you.
Thank you, sir.
Okay, thank you. Okay, what are you? They said this is almost 1 o'clock. Do we go for the break? Then we come by 2 o'clock?
Yes, sir.
Yes, sir. I think it will be preferable. Yes, sir.
Yes,
Then
sir.
the next, we now look at what do you call it? The other aspect of CP management, most especially that has to do with math and bed exercise for children with what do you call it? Developmentally, the way based on NDT. Thank you very much.
What time
Thank you.
exactly, sir? We're coming back? Is it 2 o'clock?
Yes, 2 o'clock is okay. Go.
Yes, sir.
Yes,
It's okay.
We pray, we take break, and then we now come back.
Yes, sir. Thank you, sir.
So thank you. You're welcome. Okay, good afternoon, everyone. We are all welcome back from the 1 hour break.
Okay,
Yes,
good
sir.
afternoon. Yeah.
Good afternoon,
Okay,
sir.
we are going to continue. Here we are going in this next lecture, what do you call it? In next 1 hour or so, we are going to discuss on intervention for improving motor function in children with CP. Therefore, we are likely going to run away from treadmill training, strength training, what do you call it? Constraint induced movement therapy, massage, and all these guys. We want to see how we can use what do you call it, therapeutic movements to improve motor function, most especially in the children that usually have the highest population in our pediatric clinic, children with CP who have delayed milestone. Okay, by way of introduction, we say that most of the children that were usually diagnosed with FSRC following the observation, it was following the observation of delayed developmental milestone. What we mean here is that inability to hold neck in sitting posture will lead to the diagnosis, or inability to sit after 6 months, inability to stand and walk, etc. Maybe the likely cost of referral for physiotherapy. And we said over 80% of physiotherapist's time is usually spent towards improving motor function to enable independent rolling, sitting, crawling, standing, and walking. Therefore, when we go by what we normally see in our literatures, you'll see very important research. We find out that the research is done on ambulant children, or research is done on children that have already improved to some extent. Then higher level techniques like that may not really translate to what we really want to use to practice in our clinic, because we are seeing children without head neck control, children without ability to sit. Then that is the reason why we have the second segment, so that we can rub shoulder on the little positioning procedure in order to improve motor function. In the last, what do you call it, the third bullet there, low-level developmental milestone may be the highest goal possible. In some individual with CP, the low-level developmental milestone, sitting, 4 point, 2 point, standing, may what they want to achieve. Probably they may not want to achieve playing football. They may not want to achieve running, hopping. All the parents want is low-level developmental. Highest is probably standing. Then what do we do for these children? And that is the reason why we come to this second segment. Okay, we now say synopsis. What do we really want to cover? We say we want to cover intervention for improving motor function. And these interventions include positioning interventions, handling intervention, and the guided movements that we are to give. Some of these things might be a reminder for those of us that have been practicing. Some of them, but one thing is, there is something I wrote here. Passive movement are not encouraged. Therefore, when you read all literatures in this world, there will never be any physiotherapy or any medical literature that will always encourage passive mobilization. Passive mobilization is given to somebody who actually cannot do anything, and not for the muscles to waste away, for contracture to set in. You can do mobilizations at least to improve range of motion. But if you really want to improve function, passive movement is not the way. We have to always, whatever position we give, at times there are some positions we keep children, they look good, but they don't foster motor function. They don't encourage any movement in the child. Therefore, some positions might not be discussed here. Just like when I want to sit a child and I put him in supine lying and I added pillows and I said, do like sit up. That does not encourage trunk rotation. And I will end up doing sit up for the child. That positioning may not encourage trunk rotation, and trunk rotation is one of the functions that are really needed for the child to be able to start, for the child to be able to stand, to come down from standing, to sit, and to go back to prone or spine line from sitting, and to sit again. You need trunk rotation. Therefore, some posture might not be emphasized here, probably because they might not encourage active participation in the child. Passive movements are given only where the child cannot do, probably to encourage, but actually probably to prevent contracture or deformity or to lengthen a muscle. But whenever it comes to improvement in function, active participation in the child in the treatment is very, very important. Then now positioning. The principle of positioning include alignment. You want to properly align the trunk. The child is bending to one side, and you want to properly align the trunk for comfort. Yes, the child probably has started crying. The sitting position is not comfortable for the child, or the child does not hold the position for some reasonable amount of time. It's like 1-2 minutes. The child is tired. Then you now position very well for comfort. For support, it's very, very important when the child is performing a particular movement, and then being that the child is feeble and weak, you can put your hands for support. You can put some guided positioning for support. You can use an orthotic device, even a pillow for support at least. Then we have prevention of deformity. Yes, you can do some positionings at home. After you must have observed that the trunk is swaying to one side, you can ask the mother to be taking opposite positioning for sleeping, so as to stretch the trunk for positioning and in order to prevent deformity. The readiness to move. This is the positioning that is required to provide posture from which movement occur. Therefore, you position in such a way that the child from that position will just be ready to start moving. That is the readiness for move part of the positioning. Therefore, we do positioning for alignment, for comfort, for support, to prevent deformity, and to provide this particular readiness stimulus for the child to work and to function. The next is positioning. In this case, we have to we have positioning to encourage head control, and we have movement to encourage head control. Positioning to encourage head control and movement to encourage head control. Here, head and neck control are required for sitting and standing. Therefore, it's a prerequisite for good sitting. It's a prerequisite for good standing. If the child is actually able to have good head and neck control. Therefore, they said the first position is prone over a bolster. Bolster is what we see in the clinic that looks like round, something round like this. Usually, the height of the child, much more than, let's say, 1 meter or 2 meter, usually is being round like this, like a form of a log of wood. That is a bolster. A wedge is something like a triangle. Half, if you have a rectangle, you divide into two. Half of it is a wedge. Then you have half roll. The same half roll is like a bolster where you divide it into two, and we are going to see each one of them as we move. Then we said prone is usually the first position in which the newborn experiences head lifting. Therefore, when the mother keeps the child in prone without doing anything, after some time, at the age of 3-4 months, the child should be able to raise head. In a way, that position alone can encourage head control. Visual and auditory stimulus, such as mirror, brightly colored toy, noise maker, or anything that brings noise like rattle, can be used to encourage a child to lift the head. Therefore, you can be putting something, hiking, you are making something, and in the same prone position, the child should be able to move the head. That is for positioning. Okay. Now, for example, you can see this is what you call the device. It's like a bolster that is divided into two in the diagonally. That is the half roll. That is a half of the bolster. Therefore, you can keep a child in a particular position, just positioning to improve head control. Then we have supine on wedge or half roll. You can keep a child supine on wedge or half roll. I have the little experience. The little experience I have in the clinic is that you can have a child who has developed neck control, but it's usually only in extension. Flexion, no way. Half flexion, no way. But the child is always going into extension. When you keep the child will just extend and fall back. What is happening? We overextend. At times, we stimulate the neck with our hands. When you overextend, then the extensor muscles are going to become so strong, the extension will be so strong that flexion will be difficult, side flexion will be difficult. Therefore, we have to balance up between flexion of the neck, extension, and side flexion. Therefore, here we have a wedge or half roll where we keep our child. Here we say the next flexion is more challenging. That is why they say it's more of a challenge than head extension. Yes, flexion in supine is more challenging than extension in prone. Therefore, when you put a child in prone, it may be easy to extend, but flexion in supine, even if it is you, it is usually difficult. The muscles in front are small. You only have your throat and your trachea in front. You only have sternocleidomastoid and the trapezius in front. Therefore, only few muscles compared to the muscles at the back. But definitely, you need trunk, what you call neck flexion in order to balance for neck control. When extensors are pulling back, the flexion should pull forward. We said on a wedge or half roll with the child in supine, in less difficult position against gravity, the child should attempt lifting. Then if the child is not attempt lifting, what do? They say you can provide toys or objects that is attached to a rod. You can be playing in front of the child to encourage neck lifting in front of the child. What we are saying is about just positioning, not therapeutic movement. You can see this is a ball. This is what half wedge. Look at the direction of the wedge here. You can see my what do you call it? The cursor here. You can see it is at an. You have a wedge like a triangle. Then you can put the child. The head is what do you call it? Rest a little bit. You can play with the child. Let the child be able to raise the head. This is just positioning. Okay. The other one is what do you call it? Forward flexion. Increasing the degree of trunk incline. If the child is unable to do that one, the child is very weak, for example, you can tilt the head of the bed, or you can even add pillows. You now bring the child towards standing, towards real sitting, but not up to the sitting, not up to 90 degrees, probably, let's say, 60 or 70 degrees towards flexion. You now keep the child. Then you encourage neck flexion in that direction. There, the head of the, what do you call it, the weight of the head is less compared to when the child is fully supine. The bullet one we have here, it says increasing the degree of trunk incline using a feeder seat or a floor seater. We can see it in the picture. So as the child is close to upright, then supine, what do you call it, down supine, it may be beneficial. Therefore, when you keep the child almost in upright position but not up, you can always encourage, what do you call it, neck flexion. Pillows can also be utilized to encourage neck flexion. Okay, here we have finished with positioning. Then here we are moving to interventions to promote head control. Okay, the first intervention we use here is pull to sit. We have pull to sit, we have modified pull to sit. The picture you are seeing here is that of pull to sit. You hold the arms, the child's arm, the two arms, then you pull the child to sitting. At times, you create rapport with the child as the child is, what do you call it, laughing. You pull the head. The head may lag. Look at a B. Initially, look at the head is fully lagging A, and B, the head has already started coming up. E and E. Look at C. When the child is almost upright, the head is coming. Look at D, and then look at E. Meaning that it's a way. But we shouldn't always. This is what we see, most especially with our interns, because they usually see results when they strike the neck, like this tactile stimulation, the child will go into extension. Yes, that is detrimental. With time, the child will, the muscles are, what do you call it, at the extensors of the neck will now become so strong that when you sit the child will just sit backward and will not slip backward. Okay, modified pull to sit maneuver is the same thing as pull to sit, but this time around we don't put the child. Like for example, if one does the pull to sit maneuver and the child could not pull to sit, the neck is still lagging, then he can do the modified pull to sit, where direct movement of the child against gravity, the child will now move sideways to standing, to sitting. Okay, they said starting position is supine, the child is in supine. Then they say the child's shoulders are rotated toward the PTs. And the physiotherapists begin to move the child towards sitting position in diagonal direction, not straightforward. If you observe this movement is straightforward, but the other movement will be in diagonal direction. I will show you. Yes, this is the neck. Now, we are not asking the child to look at the ceiling. The child is looking sideways. Then when we are lifting, we encourage the child to lift with us. Then now the child is not moving. It's like we are trying to put the head in gravity counterbalance position. But the issue is, it's not in gravity counterbalance position, it's at an angle, not directly facing the gravity and not 100% in gravity counterbalance position. In between, midway, that is modified pull to sit. Then the second bullet point was saying, the PT, physiotherapist, may need to wait for the child to bring the head and upper body forward towards sitting. Therefore, if you lift the child small in that direction, you may encourage the child to come forward to sitting position. Not that you sit the child. The child should be able to make some movement. At times, I use my two hands to stimulate the two sternocleidomastoid muscles in the child. The two sternocleidomastoid muscles are sitting on each side of the throat. Therefore, when you stimulate them, when you stimulate with the two hands, the head will come forward. They said sometimes the child may be able to help only with the last part of the maneuver as vertical position is approached. Yes, it's very possible. As you are lifting, the head is too weak, but as you are approaching sitting, the head will just come up. Then you know the range at which the child starts responding. Then you now can improve on that one. Okay, the next is modified pull to sit maneuver 2. Here, this is pull to sit to encourage side, side flexion of the neck. You can see the therapist hold the hand of the child with a hand to hand, but the other shoulder is supporting, the other hand is supporting the shoulder, so that we don't have the subluxation. Most especially in children with hypotonic CP, you have to support the shoulder very well. Then you now encourage the child. What the child is doing now is holding neck against gravity. Therefore, she is doing what we call side, lifting of the neck. Therefore, we have forward flexion, we have extension, and side flexion. She's doing the side flexion of the neck. You can alternate between left and right. We can also do that when you sit a child. You alternate. We are going to see it next. Okay, carrying upright. Now, this is another thing. Carrying upright. Somebody will say, the child has no neck control. What do I do? The neck is so feeble. It's so weak. Look at what is happening. Let me show you the next picture. Yes. It may be as simple as carrying the child like this, with the neck being supported by physiotherapist's chest. At least it's another thing. The neck is still supported by physiotherapy chest. I have seen an instance where physiotherapists will now tell a child, ask the mother to bring neck collar. Which neck collar? The therapist will now support the child's head, with her trunk. Then later she can now be making some moves so that the child will just be following. At least, even if the child is not doing much, that anti-gravity positioning of the head is also placing some work or promoting some neck promoting a contraction of the neck musculature. Therefore, it should encourage the use of neck muscles in development of head control. The child can be carried while in upright position. The back of the head and trunk can be supported against the caregiver's chest. Therefore, still, no matter how feeble, how weak the neck of the child is, we can start doing something. The next is weight shifting from supported upright sitting. Now, the child has learned to sit, but the neck is still not very strong. What we do is what we call perturbation. When a child sits on the laps of the physiotherapist, the two legs, the physiotherapist can easily move the child by moving the leg upside down, each of the leg upside down, moving the child from left down to right. Like, if you understand, if I am a therapist, I keep the child on my laps. Then with two legs, I can raise one of my leg such that the child can be tilted. If I raise the right leg, the child will just be tilted left. If I raise the left leg, the child will be tilted right. In a way, we are challenging the what do you call it? The trunk, and we are challenging the neck musculature. It's very, very important. They said with the child seated on PT's or caregiver's lap and supported under the arms or around the shoulder, we support the child. Small weight shift from the midline could challenge the child to maintain head in midline. Okay, the next is we are going to look at movement transitions to promote motor functions, including trunk rotation and control. We want to see, and we remember we said any movement transition that actually makes the child passive or passive recipient of care, we avoid it. We do want to use movement transition that will make the child active participant in the therapy. Okay. Number one is rolling from supine to prone. Yes, supine to prone. Supine is lying down and facing the ceiling. Prone is lying down on the tummy. That is the basic. Then they said, with the child in supine, the therapist grab the child left shoulder above the ankle with the right hand and gently bring the child knee toward the chest. What do they mean? Let me show you. Look at the first picture. You hold the child's leg, push it towards the chest, then you now turn. Look at A, this is where my cursor is, this is B. But what they are saying here is that when you lift and you are approaching, don't complete the movement until you encourage that particular other hand that is up to come forward. If you do the movement, it has become passive. Therefore, that is what they are saying. Then you now can complete the movement with the child. At times, if you do that, you can ask, what do you call it, a therapist that is close for you to stimulate the hand or the trunk of the child from behind. Then the child will follow forward. Hello? Okay. Then let's go back to the description. Therefore, with the child supine, the therapist grab the child's left lower leg above the ankle. You can see the therapist in the picture grasping the leg above the ankle with the right hand. That means with the right hand of the physiotherapist. Then they said gently bringing the child's knee toward the chest. That is the first movement. Then you will now see the other hand that is very close to that place will now lift as you are pulling the knee, the leg across the child. The child leg continue to move over the body to initiate rolling motion until the child's side is inside lying or in prone. But the most important thing is whenever you reach the middle, as the child's hand is coming up, encourage what? Rotation on the child. Don't complete the movement yourself. Okay. The third bullet is saying the side towards which the child is turned is altered, meaning that if I did 3 rotations on the right, it's better I now change to do what? 3 rotations on the left. It's altered so as to encourage side rotation. They said initially the infant roll as one lock. It is very possible that you now keep rolling. Instead of seeing the leg coming before the shoulders following, you may see the whole body following you. But they say as they mature, they may rotate asymmetrically. Therefore, what happens is the leg will now come before the trunk will follow you. Okay. The next is coming to sit from supine. Now the child is in supine position and you want to encourage sitting. And they said we shouldn't do sit-up the way we used to do sit-up for abdominal exercise because it does not involve trunk rotation. And we want to encourage trunk rotation. Okay? If it is just sit-up, we can add pillows and then encourage the child to sit. But actually what is required of him is to involve trunk rotation. They said the beginning position is supine. Now the PT position on one side of the child. Therefore, I may position on the right side of the child. I may position on the left side of the child, but the child I'm facing the child. Then it across the child body and grabs the hand farthest from the child. Therefore, if I'm sitting on the right side of the child, then the left hand is the one farthest away from me. Then the child arm is broad, meaning that the child left arm, if I'm staying on the right, is brought across the body so that he or she turns to the side and is pushing up on the other arm What they mean is that if I lift the other leg, if I lift the other hand, as the trunk is coming, the hand close to me, if I stand like this, we have right hand close to me and left hand far away from me. Then if I am pulling the left hand towards sitting, the right hand will be free. Then I'll encourage the child to bear weight on the right hand that is close to me. As I am, then I stabilize the child lower extremity so that rotation occur in the trunk as separate from what? Leg rotation. Therefore, that is very, very important. The child will be supporting, yes, the hand of the child on the right side is supporting, then I am supporting. When it is almost like the child is sitting, then I can stimulate the trunk so that the child can finish the sitting. Trunk rotation is very, very encouraged. Then we now have sitting from lying. Now, the child, remember that what we have here is coming to sit from supine. We can see it. The child is supine. We have encouraged the child to sit. Now we are saying we want to see how we can sit the child from sideline. The child is on sideline. If the child is on supine, all we just need to do is encourage what? Sideline. And you can encourage sideline with your first positioning, where you pick the child's leg and you pull the knee joints across the chest. The child will automatically rotate into sideline. Is that also? What happens is you can encourage sideline without you just doing everything. Just like this first position. Look at the first position. Look at the first position. You can encourage sideline with the first one. As you pull the leg, the knee and the hip are flexed, and you rotate across. Look at the second one. The child is approaching sideline. This one, you can encourage the hand coming, that is all. But when you encourage further, the child is going to hit prone. Is that also? You can do that. Then, now we are saying sitting from sideline. Therefore, how do we now? We can have the child.
Where's our beach?
You can have the child in prone, then you can encourage the sideline. Then, when the child is in sideline, then you can do everything. Sitting from what? Sideline. The first thing is to get the child to sideline. We assume that our child is in prone. We have seen the first maneuver. We move him to what? Sideline. The next thing is what? We want to keep him to what? Sitting. Now, how do we get it? They say sideline. Okay, I think they said the child lies on one side, facing away from the PT, with lower limbs flexed. Now, we assume the child is in sideline and we are flexing the two lower limbs. Or the lower leg should be flexed and the top leg should be what? Straight. Therefore, anyone you choose, the lower limbs are flexed, or the lower limb, the leg, or the limb that is on the lower side, if the child is in sideline, is flexed, and the one at the top is what? Extended. Sideline. Then they said, we apply gentle pressure on the uppermost part of the shoulder and a downward lateral rotation. The child should prop on elbow of the opposite hand. Okay, this is what they are saying here. Observe. The child is in sideline. We have bent the two legs. You can see where my cursor is. Bend on the two legs. Then we now apply the same hand. You can see this hand is hand to hand we hold, and the other hand is supporting shoulder. Then we now apply little help. We encourage. Then the child will now support the body with what? The other hand that is free. With that, we can encourage motion. Remember, we said the upper leg can be straight and the lower leg is what? Bent. We can do that. We can have the two legs bent, or we can have one of the legs straight because it's not impede movement and the other one bent. Then the next is, we said the PT's upper hand is placed on the child's hip. I will show you. While the lower hand assists to push up on the downward arm. What does that mean? Is that immediately the child is able to bear weight on this hand. What remains is just sitting. Is that also? What happens is this hand that is supporting the shoulder can now come and support the hip. The other hand can support the other shoulder, then the child will sit down. But the most important thing is that the child should be able to give what? Support. The child should be able to participate in the sitting. We are going to look at another one. Therefore, the child is in supine. What the therapist does is apply pressure to the shoulder, supporting the shoulder. The child should use the arm that is lower to support the body. Then the therapist now changes position. One arm should support the hip. The other arm will support the other shoulder. Then we now encourage the child to what? Sit down. The essence of doing this is for the child to be able to participate in sitting rather than do push up or sit up. Okay, it also encourages trunk what? Rotation. Okay, now remember, look at it. We said coming to sit from what? Sideline. That was what we did now. Go sitting from sideline. Then look at this one, coming to sit from prone. Now the child is in prone position, not in sideline. Remember, we said the other time the child is supine. We can easily encourage sideline. We have now seen sideline to what? Sitting. We now want to see from what? From prone. Go back a minute. From prone. They said the beginning position is prone. We elongate the side towards which the child is going to roll. We facilitate the roll to sideline. We facilitate the roll to sideline and proceed as follows. Proceed as follows in coming to sit from sideline. Okay, what they are saying here, please, we should understand. What they said is, when you have a child in prone, we assume the child is in prone. The head is on the, what do you call it? When we put the child in prone, we shouldn't allow the nostrils to be occluded. When the child is in prone, the head should be what? On the side. We should elongate the side where we are going to roll the child. This one is easy. But the last one, we say we should facilitate the roll to sideline. What they are saying is, if the child is in prone, the first thing you should do is what? Facilitate roll to what? Sideline. And proceed as follows. As it follows coming to sit from what? Sideline. What they mean is that when you facilitate sideline, then we now use the former maneuver that we use to what? To sit the child. That is one. That is what we want, coming to sit from prone. The first maneuver. The child can be in prone, then you now facilitate sideline, then you facilitate coming to sit from sideline the way we did before. That is what they are saying here. Then observe, coming to sit from prone 2. This is another maneuver. They said here it's easy. You will see it in the picture. You place one hand under the arm next to the child. There is something I want you to understand, that the first maneuver is the one that actually requires too much from the child. This one you can do much, but actually it's like the other one is more demanding to the child than this one. Then they said, place one hand under the arm next to you. Therefore, if the child is lying, then the child is lying probably from prone. Okay? If a child is lying in front of me, probably one of the hand and the hip are on my side. The other one is on the other side. They said I should place one hand under the arm. And the other hand on the child opposite hip. Therefore, if one hand is on the right arm, then the left hand should be on the what? Left hip. That is what is required. One hand on the right arm and the other one on the left hip. Okay, I want you to see this one. You can see one on this and the other one is on this. Then we now facilitate by twisting the child to come into what? Sitting. Okay, now let's go. You can see one hand is in the opposite hip. The first hand is under the armpits of the child, but that is very close to me. The armpit that is close to me, and then the other hand is on what? The hip that is a bit far away, that is opposite the other one. Then look at the second. They say you rotate, initiate rotation of the hip, and assist as needed under the shoulder. Allow the child to push up as if if he or she is what? Able. Therefore, we now initiate rotation. If you have the child, then which one rotates now? How do you see the rotation? Do you know how the rotation is? This hand that is under the armpit will now come forward. The hand that is on the hip will now move what? Backwards. The hand under the armpit will come forward. The hand under the hip will now move backwards. If you have a pillow before you, you can hold onto the pillow. You can hold onto the pillow, and then the arm under you can hold onto the pillow, the arm under the hip, under the, what do you call it? Under the armpit will now move forward. The one under the hip will now do this. to now rotate the child. Therefore,
So, sir,
let me show you. Can you see? Okay, can you see me? Hello?
yes, sir, we can see you, sir. We can
Yes,
see
we
you.
can see.
This is a pillow. And then this is the head of the child here, close to this water. And then this is the armpit that is close to me. And then this is the opposite hip. Therefore,
Sir, the
this
camera
hand
is
that is
up.
holding
Sir,
the
we are
armpit.
not seeing the pillow.
You can't really see the practical, sir.
Okay.
We're not seeing the. You cannot see the pillow.
Can you see the pillow now?
No, we can't see.
We can see the pillow.
You can see it.
The system has
Yes.
to be adjusted.
Okay, adjust. Okay. Can you see it now?
Yes, sir.
Can you see it?
Yes, we can see.
You can see.
Yes, sir.
Okay. Now,
On
look
my
at
own side, I cannot see. I can't see.
The video is going on and on.
Okay, can you see it now?
No.
Can you see it now?
Bring the camera down. Bring the
Can you see
camera
it
down.
now?
The camera should go down because the video is going. We
Exactly.
can see it. We can see the pillow.
They may not bother to show your face. They should show your hand. The camera should just show your hand level. The camera is focusing on your face.
That is it. Over there. Okay, okay. Maybe it's in the salon. Angela.
Yes. It's okay like this.
Yes, sir. We can see.
This is the head of the child, my left hand. And then this is the armpit. Look at this, the head, this is the armpit. And then look at this is the opposite hip. This is my right hand, this is the opposite hip. Yes, if this my right hand is the opposite hip. And this is my right hand is the opposite hip.
Okay, let me hip. Armpit. You just do like.
Dr. Mariam, kindly mute yourself.
Okay.
Continue. This is my right hand.
Yes, sir.
On the opposite hip. My left hand is on the armpit of the child. Then I gently rotate the child like this. Then the child will rotate. What happens is, if I turn this my left hand that is on the armpit will now go forward, then my right hand that is on the hip will now move backward. Then I see the child. Then I see fire rotating the child. If I can sit halfway, then I can stimulate the back of the child to sit down. Okay, can we continue?
Yes,
Hello?
sir. We got it, sir.
Yes, the hand that is under the armpit is the one that will move forward. The hand that is holding the hip will now move backward. Then we now rotate the child. But in the process, we should allow the child to bear weight on the hand to complete the motion.
Okay. Yes, sir.
That means for us to do this, we cannot do it in standing the way I did it. You can see the therapist is sitting very close to the child. And usually, if we are doing mat exercise, bed exercise, it's better we sit very close to the children so that we can have a very good, hold or grip on the children. Rather than us doing it while bending, we even have back pain doing that one. Okay, that is what they are saying here, that we should perform the activity slowly to allow the child to help support the trunk if necessary to sit in. Okay, therefore, we can do the first one here. Here, the child has strength, he can do it on his own. You can just give some support. Here, most especially, that is why we said in prone, here we do it for mostly for infants. We can do that to encourage trunk rotation. It's very, very important. We can also teach parents to be doing as part of home program. Okay, now positioning for independent sitting. We now agree. After some time, we must have attained some independent sitting. But the independent sitting, based on literature, involves almost 7 graded positioning. The first one is sitting prop on the 2 arms, just like this one. After the child has learned to sit, you now put the child propping on the 2 hands like this one. Then we now have the second one.
I can't see your screen, sir. Please reshare your screen.
It's shared. Some people can see.
Yes, we can see.
Yes, I can see.
We are seeing.
Okay.
We can see.
Yes. Therefore, this is the first position. They said sitting, propped on what? Forward on both arms. Therefore, the 2 arms are forward. But this is not actually the best position. This is just a beginner position. Then later, sitting propped forward on 1 arm. Therefore, the child is encouraged to lift 1 arm with play. You can be playing with toy. As the child is improving, you sit the child on your laps. You are doing all this midline shift, stimulating the trunk towards left and right until then you now put the child's back. If the child is able to lift 1 arm, then that is progress. He can have propped on 1 arm forward, then followed by sitting propped laterally on both arms. Now we have some sittings. I didn't have the video. Some children will sit, the 2 hands will be like on the side of their pockets. Here, they are much stronger than the person that puts hands forward. There is an improvement. Both hands are on what? On side. Then the fourth one is sitting propped laterally on 1 arm. Yeah, this is the normal sitting our children do. At times when you give them food to take, when they are sitting on something, they will just prop on one side. They say, no, that is not the best way to do it. Fold your legs. Is that not so? That is sitting laterally on 1 arm. Even with that one, then we now encourage sitting without arm support. That is around at the 7 months of age or at the 8th month of age. That is when the child should be able to sit without any arm support. The hand is free. That means the back is strong. Then the last one is sitting, side sitting with hand support. Here, the child bent to one side. Therefore, only one of the buttocks is on the mat. The other hand is supporting the other side. Therefore, then we have side sitting without support. You now encourage the child to lift weight. Now, the perturbation is not coming from you. Actively, the child can lift weight to one side as if one is taking an angle, then lift the weight to the other side. If the child is able to do that one, that is the highest level in sitting. Then that is the sitting positioning, meaning that now if the child has learned to sit down, then what they encourage is that we should encourage from sitting prop on both arms. Normally, They have even said it that sitting propped on both arms is not a very good position, that we should avoid it. Meaning that immediately the child reaches that position, we should try as much as we could to encourage strong, strength, so that we can move away from that one. Because by putting hands on the ground, the trunk will never be strong. The child is now using the hands to support the body. The trunk will never be strong. But when we encourage, we do a lot of perturbation, we do a lot of stimulation, we do a lot of play, encouraging the hand to move away from supporting the body, then the trunk is going to become strong. Though it's part of the sequence of development of good sitting, but the child shouldn't remain in one position such that he will not be using that position to compensate for lack of trunk strength. Okay? Then we now move from sitting. Now, the next thing is we want to move. Remember, we talk about movement transitions. Movement transitions means we should move from one movement position to the other. Now the child has improved in sitting, and we want to take the child back to prone again. The most important thing is we want to encourage the child to start crawling. Now, sit to prone. In bracket, you can see I've written, we need appreciable trunk control. They said this can be achieved as reverse of coming to sit. We have seen coming to sit, somebody putting the child is bearing weight in the hand, finally sitting down. Is that also? Then we reverse it. They said, in other words, the child laterally lift weights to one side, meaning that put one weight to one side or one hand to one side, first into an extended hand, then to what? To the elbow. Therefore, the two hands are down, then finally he goes down to the elbow. Then the next thing, prone yasam. Finally, the child turn over the arms into prone position. Therefore, if you look at if you sit down from where you are sitting down, then if you from where you are sitting down, if you turn your trunk laterally and put your two hands on probably the ground or on whatever you are sitting on, you have turned your body to one side. The next thing is, if you go down and bear weight on the two elbows, already you are down. The next thing is just to turn the hips to follow the hands. That is all. The child is in prone. But the major important thing here is going to prone, how can the hips follow the hand? Some children may find it difficult. Yes, when because the hips may not follow the hand gradually until you encourage. And here, what they are saying, positioning and movement to encourage motor function, we are not giving position that the child you just do easily. We want the child to, and remember we said trunk rotation is needed. Therefore, we want the child to assume turning the body to one side, two hands, then first on the two palms, then on the knees, on the two elbows. The next thing is the hip must follow the trunk. Then following it, the therapist will now have to help. The first one help, second one day the child will follow. The next thing is sit from to prone. This is infant. Now, the first one we demonstrated, we said it requires what? Appreciable trunk control. Those that have good sitting. Now, the second one is what? Infant. Where you need to do a lot. Go. With the infant is sitting, bend the knee to one side. Now, we assume that the infant is sitting and the two legs are folded. Then one of the legs would have to be folded forward. Let me show you the picture. Probably you see this one. This is for the infant. Observe the first one. The two legs are straight. One of the leg where the movement is going is what? Folded. Then you push the child forward to move into what? Prone position. The prone position can be on force because you want to encourage crawling. Therefore, one of the leg. But the set here is for what? Infant. If the child is having good strong control, from sitting, let him just turn the body, then go into prone, then the hip should follow immediately. When the hip follows, that is, he has good strong. But for this one is an infant. Therefore, the leg first, then the therapist can easily, with the hand in the opposite hip, push the child into prone, then hold the child hand. At times, if the hands are not so strong, the hands of the therapist may be at the elbow joint, so as to what?
support the child. Okay. Now, this is what they are saying. Remember, where are we? Here we said sit to prone infant. The other one we said sit from prone, prone from sitting, we said good trunk strength. Then we said with the infant sitting, bend the knee of the side towards which the child will rotate. This is where we have it. We bend the knee. We bend the knee towards which, that is A, we are rotating. The second one we said initiate movement by rotating the infant's upper back. This is it. The upper back is being rotated. Look at the other hand under the armpit. Then the last one, we said complete rotation by guiding the hip to follow on the until the infant is what? In prone. This is this one. This is much easier for you to do for an infant. But for somebody who has developed some trunk control and you want him to do it, that's is better as in sitting position, the way this child is sitting, you can ask him to bend the legs, then the two hands can just be on the side. The next thing you encourage, the trunk should follow. The hip should just follow the two arms. The child is in what? Front position. You are done. Okay. Usually we teach, what do you call it? We teach individuals with spinal cord injury this position. Go and get the exercises for spinal cord injury. This person is sitting, put two hands by the side, then down to the knee joint, then with one swift movement, take 1, 2, 3, then he raise the hip. He is in front position. Therefore, but for this one, it's for a small child. We do it. That is why we say the other one needs strong strength. This one need what? Is for infant, but you can encourage it. Then prone to 4 points. Now, the child is in prone position. Actually, the other one we did that involves moving the two hands to the side. Actually, if the child did not move into what do you call it, bending the elbow joint, the hand remains straight. He can easily raise the hip to follow. That is 4 points. He is straight. But if he goes into prone, he can even go on the 4 points with that positioning. Now, the rule is that they said we lift the shoulder, then we lift the hips. Shoulder first, and I put in bracket. Shoulder first, then what? Hips. Okay, this is the beginning. They say the beginning position is in what? Prone. Now, the child has assumed prone position. They say we should reach over the upper back of the child and lift gently. Now, this is the child that we have trained to be actively participating, not the child that we have trained to be passive receiver of what? Treatment. When you lift the child, look at number 1. This is the beginning of the position. You can see A here. You can see B. The hands of the therapist is on the what? On the chest. We encourage the child to bear weight on the hand. The next thing, the child is bearing weight on the hand, but the therapist is holding what? The hips. The next, the therapist now help the hips to come forward. And the last one, the child is one on all fours. But the most important thing is that we first raise the hip and the shoulder before what? The hips. We raise the shoulder. Immediately we raise the shoulder, ask the child, can you support? Immediately the child supports. What remains is what? The hip. We ask him to use the hands to come backwards. As the child is pushing backward, what happens? The hip will be raised. Some children will raise it themselves. In some, we do what? Encourage. In some, what we do is we now put a little small pillow, not a big one, that will help to raise the hip. Therefore, as the child is coming backward from using the hands, the hip will now be raised. Okay? They said lift by the shoulders. The child brings the upper arm under the body in elbow prone position. The next thing is they said continue to lift until the child is able to push on extended arm. The therapist can support the child at what? The elbows, if the child cannot have good strength in the hand. Then they said lift the hip up and bring them backward. Meaning that as the child is pushing backward to assume, what do you call it? To assume all fours, you can also help by lifting so that to help the child. As he's pushing back, then to help the child. Far enough to reach 4 points position. Extra support under the abdomen. You can use a bolster, you can use small stool, you can use pillow. It depends on the size of the child. It just helps the rest of the hip. The most important thing is look at this picture. Hafiz, can you see the picture? Yes. Look at where the child is. Look at where the arm is. What the therapist does is just to help the child raise the shoulder small. The child has started bearing. The next thing is to encourage the shoulder. Look at 3. The child to bear weight on the hand. Immediately the child will bear weight on the hand, even if the hips are not raised. She has done the first work. The next work is to encourage the child to move backward. Then the therapist will now be lifting the hip small. And the child will now reach what? Front position. No problem, go. Then the next is 4 points to kneeling. Now we said 4 points to what? 2 points. The starting position is 4 points. Now the child is in 4 points. Kneeling is accomplished from 4 points by a backward waist shift. Now the same thing, the child has assumed 4 points by backward waist shift. The child will also assume what? 2 points by backward waist shift. From the same position, the child will now keep moving again. Moving backward until when he's strong, is what? Is vertical. What is required is for the child to be able to what? Raise the trunk up. Shikenan angama. When the child push backward, it's just to raise the trunk. Shikenan is in 2 points. Therefore, kneeling is accomplished from 4 point position by backward waist shift. This is followed by hip extension with the rest of the child's body extending over the hips. Shikenan you are done. Okay, now let's see. Now, if you have a child that cannot do that, what happens? You have a child that is on all fours and he cannot do it. The next thing is the child is on all fours. You can put one pillow. You can put something that is not, can we say pillow? Look at what they said here. Achieving upright tall kneeling can be achieved by placing extended arms on benches to increase the height, to aid shifting weight towards the hip. What do we mean? As the child is coming up, but he cannot push backward and the trunk is not strong, then you can put something in front, like let's say a very big pillow that is having height. The child can press on it so as to support the trunk. See, it's on tubes. That is what you call it, 2 points. Some children with CP try to initiate this movement by using head extension. The extension should begin at the hip and should progress towards the head, meaning that when the child is drawing backward, as the child is drawing backward, the hip will now becoming extended. Then later the trunk will now become extended. Later the head will now become extended. If they cannot do it, they said achieving upright tall kneeling could be achieved by extending the arms on what? By placing the extended arm on benches to increase height. Therefore, at times it may not be benches. Probably the mother may easily now squat down and the child will now press on her back and then what? Assume this position. Gradually, the child should be able to assume on twos. The child can practice hip extension in smaller ranges before having to move through what? The entire range, which is difficult. Therefore, this is what they are saying. Some children cannot do it. Therefore, something can be placed forward, then they can now be putting their hands on it to assume that particular position. Okay. Now we move next. The next is kneeling to half kneeling. Now, the child is now on kneeling position. It's like asking people, pupil in primary school to do kneel down. He is on kneel down. Now, the next is you want to do half kneeling. Half kneeling requires that one of the knees should be on ground and the other leg should be brought forward. This is what it means. This is half kneeling. Look at the child is in kneeling position and the therapist is supporting one of the leg to come forward and the child has assumed what? Half kneeling position. Please, the therapist, this is a very difficult position. Even with people that are grown up, it requires a lot of what? Balance. That is why therapists in this position will have to support. Half kneeling to half kneeling position. The starting position is kneeling. Here are the instructions. They say you as physiotherapists have to kneel behind the child and place your hand on the child's hips. Therefore, as the child is assuming 2 points, definitely you know that position requires a lot. The gravity is actually having much impact in that position. Then you support the child's hip. Then the child must unweight one lower extremity. What do we mean by unweight? If we are moving one of the leg, like for example, the child is in kneeling position, but our intention is to move the right leg forward and the left leg should bear weight, then we must learn to unload the right leg. The unloading the right leg requires that the trunk on the leg that will support we have to shift the trunk towards what? the leg that will give supposition, such that this leg will not be bearing weight. I hope we are understanding. Therefore, if the child is in 2 points and we want to bear weight on the right leg, then in kneeling position, then we have to tilt the trunk towards the left leg so as to give room for the right leg to clear. That is what it means. Then here is the description. Shift the child's weight laterally and trunk should elongate on the weight bearing side, meaning that we should elongate towards what? The weight bearing side. With some of the trunk rotation, the child may be able to unweight and bring the opposite leg forward. Here they said if the child is unable to bring the opposite leg forward, the assistance is what? Provided. And here we have it. The assistance is what? Provided. If the child is able to do on the right, the instruction you have to do on what? Left. Gradually, today right, tomorrow left, today right, tomorrow left. Whenever the child is able to do, what do you call it? Half kneeling position, is like good to go for what? Standing. Then next is what? To shift weight on the leg that is forward and to bring the other leg forward and you encourage the child to stand. That is it. Then towards the final position is coming to stand. Coming to stand is probably one of the most functional movement transition. This is the goal that all parents that brought children to the physiotherapy department want to achieve. The time the child starts working, even if it is with working friend, you never see him in the physiotherapy department again. They will enroll him into school. The only time you see him when they are on break, that is they want this thing to happen. This can be achieved through the use of various, what do you call it, independent movement transition. Don't say the child is unable to do, half kneeling, then she can, who tell you? Even with kneeling position, you can look for something that will help the child to stand. You can do it through transition from half kneeling. You can do it from standing, from sitting on stool. The child can do, 2 points, then bring stool, let him start doing sit to stand. That will help. Standing while the child is on bolster. Yes, you can do that. If the child cannot do, it's not all children that can do stand on 2 points. Therefore, we can apply, look at the bolster here. The child is on the bolster. Look at the way the child is supporting the body on bolster. Look at the way the mother is supporting the leg. With that, if the child can stand, the next thing is you can see movement. Therefore, please, coming to stand is not obligated that the person must follow this route. You can do it, sit to stand on a bolster, sit to stand on a stool, have to knee, while half kneeling. You can come to stand from sitting on therapist's lap. The therapist can keep the patient on his lap and then encourage standing. All these ones can happen. As far as the child can do two on fours, on two, you have achieved so many things. Okay. Now, they said practicing coming to stand over your bolster can provide deterrent to lower extremity adduction, while the child works on muscular strengthening and weight bearing. What they are saying is, if the child's leg is adducting all the time, is the problem. Therefore, when you now put him to stand with the leg in between a big bolster, it is going to prevent the legs coming up like a scissoring. That will facilitate standing. Okay, let's remove this one. I think I have explained it. If the child cannot support the body weight, just like in this one, it's a bolster, the child can put some weight on the bolster, then the mother can support, or the therapist can support, and he can stand. Please, I have seen in so many places. If you go and read about Bobat, you can see standing using pole, like 2 sticks. Go and read about it in Bobat therapy. You see 2 sticks. The child is in the laps of the therapist. You now give him 2 sticks, he stands. That may be the beginning of standing. Please, I have forgotten to put this one. It's in my mind, but I have forgotten. It's part of the training. It's incorporated in Bobat. You can sit the child on your laps, and then you now give him two sticks. The child will hold onto the stick and stand. It's part of what? What do you call it? Let me add this one. Standing using what? 2 sticks. Standing with the aid of what? 2 poles. Yes, if you go back to what do you call it, Boba technique, this is also applied. The child standing with the aid of what? 2 poles. Therefore, don't say most of the children that come to our clinic, the child will do 2 points, 4 points, and still the child cannot stand. They are telling you do everything possible. Get a very big bolster, let him stand. Get this, let him stand. Start standing, even if it is on standing frame. Standing is required. Okay? Here we have the bolster. The next thing is we want to tell you about undesirable positioning methods. The first one is we said undesirable positioning for children for support and stability include children with hemiplegia shift weight on the affected side because of better sensory awareness and motor control. Yes, even adults with hemiplegia, they tend to shift weight on the unaffected side. Is that also? We should avoid it. Whenever they are walking, whenever we try as much as we could for them to bear weight on the other side, or to have, if they are sitting, they should bear weight. They should be symmetrical sitting. Weight should be borne on all the two sides. W sitting or wide abducted leg sitting. This is W sitting. Here, the major problem with W sitting, you can see it. Yes, the major problem with W sitting, the child assuming W sitting does not have to use strong muscle for postural control. They said the stability of the trunk comes from the position. Therefore, when the child do like this, everything he needs, the leg give him the position. The trunk will always remain what? Not strong. Therefore, we try to avoid W sitting. It's better we ask the child to sit and fold the legs forward, not W sitting. Then that would encourage the trunk. It's not that, yes, the child is stable here, but we never know that the child is not very stable until we now move him from the position. Is this W sitting that is giving it stability? Therefore, the child will still remain on very stable. Look at it. I put right here, sitting prop on extended arms. Is it not one level of the position of sitting that we see? It's one of the levels of sitting. But remember, we said that is just one level. You shouldn't allow the child to continue sitting. It's the same thing as props in W sitting, because the child will never use what? The trunk. When is the child going to lift arm and do something? No, the arm. That is why they said we should avoid this one. As the child gets into that position, we try to move the child away from that position. Okay, we now have handling technique for movement facilitation, home program. We now ask the mothers. We can teach mothers so many things to do. Some of the things we see here, we can teach mothers. They said positional handling should be part of every day home program. They said we should, okay. They said show caregivers the way to position and handle the child. Make it easier for the child and family to what? Interact. What they mean here is we should show them how to position and interact with the child. It will be easier for them to be able to manage the child. We should show the caregivers the way to position and handle. That is to hold and move the child to make it easier for the child and the family to interact. Look at this. They said PT could have the PT should have a snapshot of how you want the child to sit. Like, for example, you have a child that is sitting the way you want to sit. You can have a snapshot and tell the mother, this is the way I want you to start. And let me send it to you through your WhatsApp. This is how they want now. This is how you should be able to ask the mother, can you video me? The mother will say, okay, this is the way I move the child. This is the way I want you. Then the mother will now be looking at your video and then copy so that she will help the child. It is detrimental for the child to be lying at home until when they come after 2 weeks for therapy. You can have a snapshot and tell them this is how you want the child to be sitting, or you can have a little video and the family can just be using it, or you can provide, this can be used as a reminder to all family members, especially those who are unable to attend therapy sessions. So when you have it, okay, come and do it. Then that is important. Then the next is, then they say movement transition are a major part of home program. They said patients should be taught the easiest way to move the child from one position to the other. They say caregivers are taught how to encourage the infant and child to assist as much as possible during any movement. Then handling and carrying position. Okay, what are these handling and carrying position? The first one, they said hold the child with increased tone. like a child that is having severe spasticity in the lower limb, then we should always encourage flexing the lower limbs, even if it is at home. They said if it is mother, they should carry him this way by flexing the hip and the knee joint, because the child is having extensor spasticity. Okay, they say the limbs are flexed with the trunk rotated, legs are supported, trunk is rotation is encouraged. Okay, then here we said holding to stretch the hip abductors, rotate the upper trunk and dissociate it from the trunk. This is what they mean, that if the child is having what you call severe spasticity, most especially extensor spasticity in the leg, the mother can hold him this way. And this is very common. We use it in Hausa land. The mother will help him. One leg is in front, the other leg is in the back. Is that also? Flex the leg. Therefore, the most important thing is they should encourage. Look at it. The difference is that in the other side, the child is facing the mother. But in this side, the mother holds the child. The two legs are, one is in front and the other one is back, but the trunk is forward. We encourage trunk rotation. If we rotate the trunk to the left on this side, then the mother can change so that we rotate to the left on the other side. Then we now have handling in front. Holding an infant in front position over the caregiver's lap can improve what? Vestibular function. Therefore, the way we said in the clinic, we can put the child in front. The mother can also be putting the child in front at home to encourage what? Vestibular function and to encourage neck lifting. Okay? The next is now handling methods to avoid picking up a child under the arm. They always used to pick children under the arm. They said if you have a child with severe extensor spasticity in the trunk, you have a child with with floppiness, meaning that the child is very floppy, hypotonic. Then they said it may be detrimental. A child with increased lower extremity tone should not be picked up under the arms. The legs usually stiffen into extension and may even cross, meaning that it may lead to seizure. That's one. The second thing they said, also some pickups method could be avoided in the presence of low tone. Like for example, the same pickup method. They said the child shoulder girdle stability may not be sufficient for the caregiver to hold the infant safely. Therefore, instead of holding the arm, you can also support the trunk. But the most important thing is support the trunk and the legs. That is the most important thing. Okay? The next, this is what they mean. This is contraindicated for a child with extensor tone. It's better you bend the leg and the trunk. Okay. Now, conclusion. We said attending lower level developmental milestone may be the highest goal possible for many children with CP. Many cannot walk, but achieving standing and be able to take some step is the most important thing they want. Position handling and guided therapeutic exercise technique should encourage active participation of the child with CP. I will say thank you for listening. We are done with this one. Thank you very much.
Thank you, sir. It's highly educative, actually.
Thank you, sir.
Yes, actually, we felt that what we need more in our clinic is this one compared to the other one. The other one is more of research, but movement transitions for the patients that we usually see, majority of them are in positions where we need these things to be helping them. And the next is, we really don't have much time. This is 3:23. We still have some, some modules. Go. Let me move to the next module. The next module is spasticity. Okay, we are going to look at spasticity and physiotherapy approach to managing children with spasticity. We have already started seeing spasticity when we are discussing CP as a whole. But remember, we have defined spasticity as velocity-dependent increased resistance to passive muscle stretch. In some instances, they added something. They will tell you it's velocity-dependent resistance to passive elongation of muscle when the patient attempts full relaxation. meaning that when the patient is tensed up and you say this is spastic, that is not spasticity. They said when the patient attempts full relaxation and then you now pull the limb either fast or slow, and you now feel resistance, that is spasticity. Therefore, it is defined as velocity-dependent increase in resistance passive stretch when the patient attempts full relaxation. Another definition, alternatively, they define is as inappropriate involuntary muscle activity associated with upper motor neuron paralysis. Therefore, they define it as inappropriate involuntary muscle activity associated with upper motor neuron paralysis. These ones are definitions of spasticity, but the most important definition is the first one. Okay, now what are the consequences of spasticity in children with CP? We said it aggravates motor disability. Yes, actually it makes the muscle stiff. It makes the child immobile. It makes the child dependent. Therefore, it increases disability. It leads to abnormal posture. Therefore, instead of seeing the hand straight, the hand will be bent. Contracture will set in. That is what they mean. It impairs standing and walking due to clonus scissoring. Therefore, the child may be able to stand. Remember, we said when we are dealing with bolsters, leg putting across bolsters, at times the two, adductor muscles may be so tight that they may want to stop the child from walking. You have to put something in between the leg to help the child be able to attend standing and walking. It stores voluntary movement due to flexor and extensor spasticity. Therefore, when you have flexion or extension spasticity, therefore voluntary movement in children, things they do for themselves may be slow, because most especially in children with CP, they experience what you call co-contraction. At times, the agonist and antagonist will be contracting the same time. Even if the child is going to achieve the movement, it will be slowly, because the other antagonist muscles are supposed to relax. When these ones are contracting, refuse to relax. Okay, affect proper positioning, difficult for sitting and transfers. Yes, some children that are too, let's say, in extension in synergy or flexion in synergy, sitting them will be difficult. Standing, some of them will become difficult because of what? Abnormal postures. Okay, we said it increases risk of contraction and joint subluxation. Remember, in management of children with CP, we said any child that has severe spasticity in the hips, we should be careful in mobilizing the hip joint, because mobilizing a very spastic hip joint can lead to what? Hip joint subluxation. Okay, it causes difficulty in hygiene and dressing. Yes, the mother want to bath the child. The hand cannot come forward for her to clean the armpit. The mother cannot clean the two legs that are together. Yes, probably the two legs are together, the hamstring and the back of the gastrocnemius, they are together. It makes it difficult. At times the child will be it will look like rock, even for the mother to bath. Then spasticity make it difficult for them for hygiene, bathing, and dressing. It predisposes to pressure sore. I remember we say secondary to immobility. If the child is not mobile, the spasticity have made him assume a bad posture. If care is not taken in that particular position, it's going to develop pressure sore. Spasticity produces pain. It's very, very common. If the therapist did not move the spastic limb gradually and gently, and at times it's better you massage, you do everything so as the spasticity would go, even if it is momentarily, before you move. If not, these children usually suffer from serious muscle pain. And it inhibits muscle growth. That is what used to happen in diplegic children. When the hip is flexed, the knee is flexed, the ankle is flexed. When you want to stretch the hamstrings, because the knee is flexed, the hamstring will now refuse to grow. At times, the lack of, the contraction we see is not the product of spasticity alone. It's the problem of lack of muscle growth. When the muscles are being put in shortened position for some time, there is no stimulus of movement. Therefore, they refuse to grow. Only the muscles that are being put into flexion and extension and rotation keeps moving. This one refuses to grow in length. Therefore, it leads to shortening of the muscle. Therefore, spasticity would inhibit muscle growth. then it masks muscle weakness. Yes, at times you move the limb of a particular patient. You say, "Guy, when about position the legs are too strong," but actually not knowing that spastic muscles are weak muscles. If you give anybody medication that weaken the spasticity, you now see that the muscles are very weak. Spastic muscles are weak muscles. It is just spasticity that is making them look strong, but they are weak muscles. Okay, we have positive effects of spasticity. The extensor tone in the limbs of hemiplegic children helps with standing. Therefore, most children with hemiplegia, when there is extensor tone, they can bear weight on the leg, just like in what do you call it, adult hemiplegia. Usually, the hands will not come, but because of extensor spasticity in the leg, they will bear weight. They said it preserves muscle bulk. Yes, when you compare spasticity and flaccidity, the muscles that when somebody has lower motor neuron lesion, like let's say Erb's palsy, it is easy for you to see wasting of the muscles, but in spasticity, no way. The muscles will waste but little because there is always inherent electrical activity in the muscle. The muscle wasting is not like in what do you call it, flaccidity. Therefore, it tends to preserve bone density. Therefore, their bones don't become very, very brittle compared to those ones that have what? Lower motor neuron lesions. Then the management of spasticity in general with CP ranges from physiotherapy, oral medication, botulinum toxin injection, phenol injection, selective dosal rhizotomy, intrathecal baclofen, and orthopedic surgery. And we are going to talk about them little by little. Physiotherapy management. Here we are discussing physiotherapy management with evidence. Then we are likely going to see potential physiotherapy management with less proven efficacy. Okay, now we are starting with the use of orthotic device and serial casting. To date, the literature, all the literature you read, they will tell you physiotherapy devices such as orthotic devices and serial casting are important in the management of spasticity. Spasticity used to lead to limb, becoming deformity and becoming deformed in either flexion or what? Extension. We apply orthotic device to stretch them. We apply serial casting to stretch them. The serial casting can also inhibit spasticity and make it less active. Therefore, they said orthoses are designed to provide joint stability, to hold a joint in functional position and to keep tight muscles stretched. Orthotic devices provide prolonged stretch that offer biomechanical benefit and inhibits what? Spasticity. Therefore, we need sustained passive stretching. But for how long? For 5 minutes, the physiotherapist will just stretch for 2 minutes and he has become tired. That one cannot do anything. Therefore, you need stretching that will last 5-10 hours to inhibit spasticity. We have serial casting. It is done to lengthen already shortened muscle. Okay, the difference between serial casting and orthotic device. In serial casting, we only think of serial casting when you have the muscle has become what? Adapted to your shortened position. Deformity has set in. You have no option to either do surgery or serial casting. But in orthotic device, you can start applying it on the leg. Immediately spasticity set in. It will now be keep stretching and leaving the limb in therapeutic position, and it will never develop severe spasticity, and it will never have, the child will never have contracture and joint deformity. Therefore, serial casting is already when we apply it when the muscle is already shortened, and soft tissue are also shortened, and to prevent or correct contractures. Okay, then we have precautions against serial cast application. The longer term of serial cast, up to 6 weeks, and it is changed every 2 weeks, can cause weakness of antagonist muscle. One will say, okay, let me give you an example. Like, for example, you have biceps muscle that is weak. Your leg is, your hand is in flexion. And then you are using serial casting. What serial casting does is you stretch the arm, probably it comes to 90 degrees, then you apply serial casting. After 2 weeks, you now come, they will break the serial cast, then they will now mobilize the hand, they will now extend to another region, then cast again, until when your hand is straight. But the major problem is, when they do serial casting after 2 weeks, when they come back, your extensor muscles in the triceps, when you test them, you find out that in that 2 weeks that you put the hand in serial cast, both the flexor and extensor muscles are becoming what? Weak. Then in that case, serial casting can be interspersed with strengthening exercise. After you do it, you have to give some few days of strengthening exercise, then you now apply it. If not, then it will not be detrimental. You have achieved range of motion, but you have lost function. That's it. Then the second one is they said casts are often now applied in shorter period, change more frequently. Like every 5 to 7 days you change it. Every 5 to 7 days you change it. We intersperse with certain exercise and the patient will continue. Then we have strengthening exercise. Please, this one has no second when it comes to spasticity. After you must have done your serial casting, when the muscles are weak, where are you going? Is it not strengthening exercise? After you must have given medication, when the muscles are, the weakness have become apparent, what comes to you? Strengthening exercise. When you apply a toluene injection, you apply phenol injection, you apply Botox injection. Therefore, they are going to weaken the spasticity. What happens is what the muscles are going to purely weak. What you need, strengthening exercise have no second. Therefore, targeted muscle strengthening exercise improve the strength of the weak muscles, has benefit in specific clinical situation in cerebral palsy. They said intensive training is required post Botox injection, phenol injection, and following selective dosal what? Rhizotomy. Even the surgery they do at the back, it weakens the muscle. Therefore, immediately that one, when, like for example, if they said your tissue monster wants to start doing Botox injection, the next thing they know is physiotherapy is very important. They need strengthening exercise. The next thing is neuromuscular electrical stimulation. We have talked on this before. Systematic review by O et al. Has found that electrical stimulation decreases spasticity in patients with what? Cerebral palsy. But remember, we said it. This spasticity is focal spasticity, not global spasticity. Focal spasticity of biceps, triceps, hip flexors, extensions. The muscles that are very small altogether, those ones are focal. You cannot approach all hip extensors, you have to look for another thing. Focal muscles, okay. Okay, less effective techniques now. The effective techniques that are less effective is our manual stretching. The one we used to do before we start managing children with it. We just do little massage and we stretch. Is that also? Yes. They said for you to have something reasonable, you need at least 60 minutes of stretches to produce maximal effect of spasticity. Has the therapist hold for a 60 minutes? That is why you need orthotic device. Go. You now can apply your orthotic device. Is it cock-up splint? Is it what you call it, back slap? Whatever you want to apply that will last for 2 or 3 hours, that will now have more effect on spasticity. Then they said this implied that sustained passive stretches of 5 minutes delivered by Hello?
No, Annie, Bombo yet.
Okay, some people have to be muted.
Okay.
Okay. They said this implied that sustained passive stretching up to 5 minutes delivered manually by physiotherapy may not lead to significant reduction in what? Spasticity. What do we mean? The little sustained passive stretching we used to do in the clinic, before we do it, is short-lived. Even before you finish the treatment, spasticity has come back. Is that also? Okay. They said only orthotic device can deliver therapeutic stretching, consistent fashion, provided compliance is maintained for a lengther period of time. You have applied, the child is really complying, then you now see the stretching you want is being what? Achieved. Then thermotherapy. This is also one of the less effective treatment. They said not usually applied to children with CP because of what? Fear of bones and injury. Some of them cannot report. Therefore, you are looking for a person that is lying, not moving. If he has bones, it's another complication. Oh, we try as much as we could not to apply heating on him. They said moist heat and infrared decrease muscle tone, reduce muscle spasm, and increases and decrease pain, please. And decrease pain. The effect on spasticity is what? Short-lived. Whatever you do with thermotherapy, before you finish treatment, spasticity has come back. That is what they say. Then the next thing is what? Cryotherapy. It is not usually applied in children with CP. Because of what? Fear of forced bite injury. They may likely got burned. Therefore, it temporarily decreases spasticity and clonus. They said it reduces spasticity mainly by reducing the sensitivity of low threshold afferent and muscle spindles to stretching. Therefore, it reduces the sensitivity of the muscle spindles that are actually being overstimulated. Okay, now we have a potential therapy we call extracorporeal shockwave therapy. Extracorporeal shockwave lithotripsy. Please, the one we use in the management of kidney stone is called extracorporeal shock wave lithotripsy. And then the same is the same using the same principle. This is extracorporeal shock wave therapy. The shock waves are sequence of single sonic impulses. What is sonic impulse? Meaning that they are ultrasound impulses, characterized by high peak pressure, fast pressure, and short duration, like 10, seconds. They said the mechanism through which shockwave lithotripsy induces changes within tissue is remain uncertain up till now. They said it has application in many orthopedic cases and kidney stones, like the lithotripsy we are saying. Extracorporeal shockwave lithotripsy is the one that is used for kidney stones. They said it is proposed for the management of abnormal muscle tone. There are researches, but up till now, researches more and more are going on the use of shockwave lithotripsy. Now, we move to oral medications. We are now looking into what? Medical treatment. Oral medications are systemic rather than focal treatment for spasticity. Therefore, when they are saying spasticity treatment, nearly all oral medications are made to treat generalized spasticity. Having spasticity in the two legs, the two hands, everything, not focal spasticity, because they are systemic. Therefore, their effect is general. If they are making the child weak, everything will become weak. Then they said, they give example of benzodiazepine, like for example, diazepam is a short-term spasticity medication. We have oral baclofen, not widely used in children with CP. Then the other one we have baclofen and other medication that include dantrolene and tizanidine. The most important thing is that thing is that whenever we have our children with CP coming for treatment, when we look at the medications they are taking, we know this is medication for spasticity. We may know this medication is either for spasticity and epilepsy, like diazepam can be used for spasticity and what? Epilepsy. Okay, botulinum toxin injection. This is the most widely used treatment for focal spasticity. What is focal spasticity? Like for children that are having cerebral dysplasia. Yes, focal spasticity of hamstring, focal spasticity of then we now deal with it straight with botulinum toxin injection, because it's one of the big problems for them to stand. The hips may be ready to stand, but the hamstring will say no. Therefore, focal spasticity, we use it. The toxin inhibits the release of acetylcholine at neuromuscular junction. The toxin is injected directly into the targeted muscle and takes 10 to 14 days to achieve visible effect. Then they said Botox injection are given in conjunction with intensive physiotherapy to obtain maximum benefit. And then why do we say intensive physiotherapy? These guys are spastic muscles. The spastic muscles are weak muscles. The only thing is that immediately apply, like, okay, somebody will ask me, how do we know they are weak muscles? Is it not the medication that make them weak? No. The same you will take Valium, diazepam. Is that also? Yes, it's the same me that will take diazepam or Valium, but it will only make me, let's say, sleep. But my muscle strength will not be affected. But in these guys, because it weakens the spastic muscle, it reduces the spasticity, then the muscles appear what? Weak. Then they need intensive physiotherapy. Intensive physiotherapy to increase the muscle strength in these guys. Then we now have phenol injection. Please, phenol give what you call irreversible neurolysis. What they mean is that if you give phenol injection in a particular muscle, the effect is irreversible. The effect is irreversible. Usually, in doing phenol injection, they use what they call stimulation technique. They use electrostimulation to get the real muscle they want. What they will do is the hyperactive nerve that is affecting the muscle will now be given phenol. Then it's irreversible. Then physiotherapy, but they will not give it to a nerve that does not have other tributaries. They only give nerve that has other branches. Therefore, when they deal with the main trunk that is giving spasticity, the other branches will remain. Then with intensive physiotherapy, they will now come up. Okay, that is what they do. Probably they will give one of the main branch that is to give. If it has 3 branches, they will now block 1 or 2 of the main branch. Then it will now become weak. The therapy will continue. But they will not block all the branches. Okay. Then they said phenol is an alternative option for focal spasticity management. It is used alone in a combination with Botox therapy, particularly in small children where body size restrict appropriate dose of Botox. Meaning that if the dose of botulinum toxin is too much, the child cannot, the dose required for botulinum toxin is high for a child. Then they can use it, they can give phenol injection instead. And then they said it is used mainly to block obturator nerves in ambulatory children with scissoring gait. Therefore, mainly they use phenol injection to block and obturator nerves. But remember the nerves that have other tributaries so that the child will not become paralyzed in child with scissoring gait. Okay. Then we now have selective dorsal rhizotomy. Selective dorsal rhizotomy is a neurological procedure in which of posterior rootlet, the posterior rootlet in our back. Remember our what do you call it? Normal neural arc in our back. We have interneuron, we have motor neuron, and what? We have sensory neuron. That is the reflex arc. Is that also? Therefore, what they do is they go and interfere with the reflex arc. They will now remove the sensory, rootlets. Only the motor rootlets will be there. The sensory rootlets will go. Therefore, it will reduce hyperactivity of the muscles. It reduce, eliminate spasticity, improve range of motion, and improve function. Therefore, this is selective dorsal rhizotomy. This is the arc in the back. What they do is they remove the rootlets here. They remove the sensory rootlet. That is the why we have the name selective dorsal rhizotomy. The dorsal meaning that the rootlets that are sensory are the ones that are removed. Physiotherapy should also note that the children with selective dorsal rhizotomy have lost sensation in the lower limb. Therefore, all forms of sensation in the lower limb, the motor function is there, but the sensory function is lost. Therefore, you have to protect the leg. They should always wear canvas. They should also always protect the leg. If not, they will become injured without their notice. Then the next is, okay. They say ideal candidate for selective dorsal rhizotomy is a child over the age of 3, diagnosed with spastic diplegia, a CP child with reasonable balance and strength and motor control. Why do they that? Immediately you remove the dorsal rootlets, the child is going to become weak. Only motor act, but sensory part of the reflex act is gone, the child is going to become weak. Therefore, he must have some reasonable balance and strength and motor control. Then extensive physiotherapy follows. They said a child with absence dystonia or ataxia. Therefore, if the child is having dystonia or ataxia, should not be given selective dorsal rhizotomy because he needs to have good balance. That is the reason. Okay, the child with CP that can cooperate with post-operative rehabilitation. They say the spasticity should be significant enough to cause difficulty with function. If the spasticity is mild, oral medication or other forms of spasticity can be measures can be used. Then we have intrathecal baclofen. Here, the same baclofen that we give orally. The major problem with oral baclofen is that it leads to withdrawal syndrome. And then they say it passes through blood-brain barrier. It does not pass through blood-brain barrier very well. It has slow absorption. They said higher doses are needed, and these higher doses can lead to tremor, can lead to arrhythmias and tremor. That is why it is not usually used. Then they now devised a means of giving it intrathecally under the skin. They said ITB was approved for treatment of spasticity of cerebral origin in 1996. And it is used to treat spasticity of both spinal and cerebral origin. You can have spasticity of spinal origin, that of spinal, like for example, spinal cord injury. We can have that of cerebral origin, like that of what? Cerebral palsy. We said a baclofen pen is surgically implanted in the abdomen or back of the patient under the skin. It is it infuses baclofen directly into the spinal canal and around the spinal cord. This is how it is. You can see the baclofen pump here. You can see the cord here that releases the drug directly into the spinal canal. Okay. Baclofen inhibits spasticity by blocking extrasensory neurotransmitter in the dorsal horn. Therefore, you can see the other one, even dorsal rhizotomy, they remove the dorsal rootlet. This one also is what working on the excitatory neurotransmitters on the dorsal horn. They said it maximizes the dose delivered to spinal receptors and minimizes the side effect associated with oral baclofen. Oral baclofen has a lot of side effects. That is why it is less popular. They say candidates for intrathecal baclofen are mostly likely to have moderate severe spastic quadriplegia and are usually 45 years of age or older. Now, look at it. In all others, when you talk about phenol injection, they say they give to obturator now. When you talk about botulinum toxin injection, they say spinal bifida and what do you call it? Cerebral diplegia. But baclofen, they said for what? Quadriplegia, meaning that somebody that is having generalized body spasticity is the best to take care of it because it releases enough dose of baclofen into the bloodstream. Okay, what are the disadvantages of having what do you call it? Having intrathecal baclofen? Pump malfunction. At times they will do surgery, put the pump, but the pump may malfunction. Therefore, it leads to withdrawal syndrome. It's one of the drugs that lead to withdrawal syndrome. The child is going to develop withdrawal syndrome, similar to the one people experience when they stop taking narcotic analgesics. Okay. Conclusion. In children with CP, spasticity management involves physiotherapy, medical, multidisciplinary approach to spasticity management is the only panacea to spasticity management in children with CP. Okay, thank you for listening. We are done with spasticity. The next is we are going into presentation. We are moving together. Hello. Hello. Okay. Are we together?
Yes, sir, we are together.
Yes, sir.
Yes, sir, we are together. Then
Hello, are we together now?
yes, we are hearing you,
Okay.
sir.
Okay, we are done with spasticity management.
Okay.
And then, yes, because this is almost 4 o'clock. Let's see if we can go over the last module, that is epilepsy, a seizure and epilepsy. Therefore, we are going to the last module. Okay. Are we free? Can we start? Hello?
Yes.
Okay.
Yes, sir.
Sure, sir.
Okay.
Yes, yes.
Good afternoon. We are taking the last module. We are taking the last module for the day. That is epilepsy. It's not very common in our literatures, but actually we manage children with CP that have comorbid epilepsy. At times, it is when we are managing these children and they start convulsing, we now say, okay, this child is having epilepsy. And with time, we have renewed interest now as physiotherapists because we have started seeing some benefit effect of some physiotherapy techniques, most especially aerobic exercise in individuals with epilepsy. We now said as a beginner lecture today, let's see what we can do. Let's remind ourselves about something about epilepsy, and then the treatment approaches to epilepsy, and the little physiotherapy can do to individuals with epilepsy. Okay, by way of introduction, we said epilepsy is a brain disorder in which clusters of nerve cells or neurons in the brain sometimes signal abnormally. Just like the way you have, what do you call it, inherent electrical activity in the muscles causes spasticity. Yes, in epilepsy has to do with diffuse electrical activity in the brain, something that the child cannot cope with. It's like the whole brain will now become disorganized at one time because of diffuse electrical activity. That is why they said sometimes the neuron signal abnormally. A diagnosis of epilepsy is not given unless a person has had more than 2 seizures. Therefore, when a child has seizures and you are able to say, okay, this is seizure, and then he has another seizure at some time, then they now note it. He still have another seizure sometime, then they will now begin to say, okay, let's go for EEG, electroencephalogram, to see whether this child is likely having what? Epilepsy. Just like the way we used to have our hypertension, when you measure the first one, second time, if you measure for the third time, you are still having high blood pressure, then it's likely going to be hypertension. Then one has to be on drugs. They say seizure may occur in the presence of precipitating factors, such as high temperature. Yes, at times, when you have children, most especially if you are doing a program outside the house, like you go to the football field, you go to watch parade, when you carry small children, high temperature will make them start convulsing. Or alcohol, or drug withdrawal, the way we say in baclofen. Yes, some people, because of withdrawal of baclofen, or the pump has started, intrathecal baclofen has malfunctioned, then the child will now start having convulsion and seizure. Then, or hypoglycemia, somebody who is hypoglycemic and wanted to pack will now start convulsing. Then they said it may be a precipitating factor. Then we now have seizure classification. Majorly based on the current classification, we have 2 major classes of seizure. We have what we call the generalized seizure, and there is what we call the partial seizure. Generalized seizure. Here in generalized seizure, they say it's produced by electrical impulses from the entire cortex, meaning that the entire cortex is confused. Then partial seizures produced by electrical impulses associated with abnormality, structural abnormality in the brain. Like, for example, children with CP probably having structural abnormality in one side of the brain, affecting probably what do you call it? A complex of nucleus in the brain. Like, for example, the one where they have Rolandic, what do you call it? Example, we have the Rolandic seizure, or what they call, they have, I've forgotten the name, but I remember, you could call it Rolandic. It affects only the giant pyramidal cells of bed. We call them Rolandic seizure. Therefore, the afocal, more of what? Partial seizure. Just the other one is generalized. Okay. Then we now have generalized seizures. We call them the tonic-clonic or grand mal. We have the absence of petit mal. We have myoclonic and what? Atonic. Tonic-clonic or grand mal, absence of petit mal, myoclonic and atonic. Then we have partial seizures. We have simple partial and complex partial. In simple partial, they can be sensory, motor, autonomic, and psychic. In complex partial, they are also called temporal or psychomotor, what do you call it, seizures. Okay, then we now have symptoms of tonic-clonic. We are now looking at the first group, the generalized seizures. Remember the generalized seizures, we have tonic-clonic, absence, grand mal, myoclonic, and atonic. We are now going to the symptoms of tonic-clonic. Tonic-clonic is also referred to as grand mal seizure. It leads to loss of consciousness. And then the tonic phase, that is the stiffness phase. The individual becomes stiff and fall to the ground. Then we have the clonic phase, that is the jerking. When the individual has started moving the extremity, the individual may bite his tongue, may foam from the mouth. Yes, it is easy for you to see somebody fall down, then he may lose some consciousness after 1 or 2 minutes. He may have drooling from the mouth. The tonic phase is the stiffness. The clonic phase is the jerky movement. Some people may even pee on their pints. That is tonic-clonic seizure. It's a general seizure. It's produced by generalized diffuse electrical activity in the brain. Then we now have post-ictal. After the seizure is over, what happened? Then they said the individual become lethargic. The individual become very weak. He knows something is bad. He will become very weak. Then may fall asleep. He may become confused. May have slow speech, headache, soreness, disorientation. Okay, we have the next is absence or petit mal. Here in absence, the symptoms include brief loss of consciousness, in which is blank. Hello?
Please share your screen.
Okay, the screen is, let me share it again. Sorry. Okay, are we done?
Okay,
can you see the screen now?
Yeah.
Yes. Therefore, in absence of petit mal, remember the first one is the grand mal. That is the oga pata, that is loss of consciousness, tonic-clonic phase, and with a lot of troubles. Then we now have absence of petit mal, brief loss of consciousness, which there is blank staring. Yes, actually, I have experienced some people having petit mal. Somebody you are talking to will now, it's as if something has taken over his attention. He would, like, for 1-2 minutes, he'll be away from you, then he would come back. That is absence. Or you can see 20 to 15 seconds, but sometimes 1-2 minutes, somebody will just come back. That is what petit mal may be preceded by rapid eye blinking. Yes, usually some of them will have very rapid eye blinking. Okay, may have numerous seizure a day. Therefore, in ictal may be unaware. Therefore, post-ictal, when that happens, may be unaware, that they have lost time. Somebody who has this 1 or 2, 15 or 20 seconds or 1 minute, he is unaware that he has lost time. He is doing some work and that thing occur. He has already lost some minutes, but he may not be aware. That is post-ictal. Therefore, the one that easily, even in history, you can easily get is the petit mal and the grand mal, that somebody will fall down, lost consciousness, may even have some bruises, may even pee in the pint. That is the biggest one. Then we now have myoclonic seizure. Remember, we have what do you call it? Okay. Then we now have the myoclonic seizure. We have sporadic synchronous bilateral jerky movement of the body and extremities. Most result in dropping or voluntary throwing things. Last for 20 seconds. Okay. Now, what is the difference between it and the grand mal? They said there is synchronous bilateral jerky movement of the body and extremities. Therefore, the other one will now have stiffness and then later movement of the extremity. But this one is not tonic-clonic. It's what? Synchronous bilateral what? Jerky movement of what? The extremities bilaterally. That is myoclonic seizure. The first one has to do with what? Tonic, stiffness, clonic, movement of the extremities, and loss of consciousness. But here, there is no loss of consciousness because they didn't say it. And they said it lasts for what? 20 seconds. Another difference between it and tonic-clonic, no loss of consciousness. In this one, the other one has loss of consciousness. This one is bilateral jerking movement of the extremities. Then the last one is atonic seizures. Sudden brief loss of consciousness and postural tone lasting 15 seconds. Head may drop, may fall to the ground and drop objects. But there is something we should understand, the difference between it and the other one. This one may also fall. The other one has tonic-clonic. The other one has generalized jerky movement of the extremities, but this one none. But this one has what? Loss of consciousness. But none of what? Either tonic or clonic, none of jerky movement of the extremities. That is why they call it atonic. Atonic meaning that no stiffness. Atonic, no stiffness. Only this. That is the reason. Atonic. But the other one said there is tonic, there is stiffness, and there is what? Clonic. There is jerky movement. Then we now move to partial seizures. Remember, partial seizures are divided into two: simple partial seizures and generalized partial seizures. We have simple partial seizures. Then we have, they said, remember in simple partial, it may be sensory, it may be motor, and it may be what? Autonomic and psychic. Therefore, we have simple, sensation of vision, hearing, smelling, taste, or touch. Therefore, the individual may simple partial seizures may be his own. If it is sensation, he may have unusual sensation of vision, probably seeing what's supposed, or hearing, or smelling, or taste. Then motor system may include stiffening, jerking, spasm of the body, may spread to other parts. But remember, when we talk about the first one has to do with entire body affectation. Remember, in partial seizures, we said one focal area of the brain is usually affected. But in general seizures, we said there is diffuse electrical activity in the brain. Therefore, there is stiffening, jerking, spasm of one part of the body. Therefore, here is just one part of the body. The other one is general body. And the individual, that is the motor part of it, the sensory part of it. After the jerking movement, he may have hearing, smelling, and abnormal sensation of hearing, smelling, and this. Then, if it was autonomic aspect, the individual may have changes in heart rate and sweating. Therefore, the heart rate may slow, or the heart rate may increase, and the individual may have what? Sweating. And then they say post-ictal, the individual may have memory of what? The seizure. It may keep occurring to him, the memory of the seizure he has. Therefore, they look at it, they say psychic. That is what brings about the last one, sensation of fear. Always having fear of seizure, depersonalization, anxiety. Therefore, the simple partial seizures may have sensory part of it, sensations of vision, hearing that are abnormal. The motor part of it may be jerking and spasm, but of one part of the body, which is actually what generates the other one. Then the autonomic and psychological functioning of the fear and anxiety is there. Then we now have generalized or complex partial. Then under we have complex partial, previously called temporal or psychomotor. We have autonomic involvement, automatic movement, such as lip smacking, chewing, fidgety, and picking. This is complex partial. Automatic movement such as lip smacking. Then we have chewing, fidgeting something as if somebody is pulling something. Then we have and picking. Then we have status epilepticus. What is status epilepticus? Is that in nearly all the seizures, you see 10, 15 seconds, you see not up to 1 minute, in highest probably 1 minute, but in status epilepticus, we see seizure lasting more than 5 minutes. If somebody lies on the ground and it lasts more than 5 minutes for him to come back to consciousness, then they call it status epilepticus. Therefore, then the set is as a result of 2 or more seizures occurring without the return of consciousness between seizures. For example, somebody having grand mal for 1 minute. Before he recovers, he has another seizure. Before he recovers, he has another seizure. Therefore, when you have 2 or more occurring, the individual is likely going to become on ground for 5 minutes or more. Then that is status epilepticus. You may have a seizure, but before you recover, another seizure occurs. Before you recover, that is what leads to the status epilepticus they are saying. Now, safety for procedures for seizures that involve loss of consciousness. Are you a physiotherapist working with patient? Are you somebody who is close to a place where the patient with epilepsy is being worked upon? Are you the person that invites somebody with epilepsy because you heard that exercise can have positive impact on seizures and epilepsy? You invite them to come for, what do you call it, training in your research center. What do you look for? What are the precautions and safety procedures? One, they said immediately somebody is down, you lower a person to the ground, meaning that you should what do you call it, lie him down appropriately, because individual may fall on a bed, may fall on something, you lie him down appropriately. Turn the person on the other side. Turn the person on one side. What it means is that if somebody, they may likely vomit, therefore when you turn them to one side, when vomiting occur, they may not aspirate, they may not ingest their vomiters. Therefore, they may not end up having pneumonia or chest complication. Therefore, when you turn somebody to one side, the patient may likely vomit. Therefore, they may not inhale their vomiters. Then they say we should protect the head. Therefore, if we are working with people having epilepsy or this, we remove objects in the vicinity that may cause injury. Then they said, losing any restrictive clothing. If there is any restrictive clothing on that individual, either he wears belt or he wears anything, you losing it. Then they said, keep record of the length of seizure. It's important. If somebody has lied down for 5 minutes or more, then you have to take him to emergency. He needs medical attention. That is status epilepticus. If it is only some few seconds, then the person may recover. You may also attend to him. They said, do not insert anything into the mouth. Some people may be biting the tongue, then some people may be putting something again inside the mouth. They said, don't insert anything inside the mouth. Don't restrain the person. If this person is jerking, like myoclonic, the 2 hands and the 2 legs are what? Jerking. They said, don't hold him like this. Don't hold him, because some epilepsies come with what? Autonomic dysfunction. Probably the blood pressure, the respiratory rate, and everything would go high. Therefore, they restrict the individual. Allow him, he's going to come down. They say, if the seizure lasts for 5 minutes, get medical attention, meaning that it's status epilepticus. Stay with the person until he or she regains consciousness or medical attention arrives. Therefore, when we are working with somebody with epilepsy and something's happened, make sure that we remove all the tight clothing from him. If he's jerking, we can stay with him, but we shouldn't restrain by holding him. That may not stop anything. Then we should make sure that we monitor the length of the seizure. Then we can call for medical attention if it lasts more than 5 minutes. Okay, physiotherapy examination. They say the onset, nature of seizure, and any precipitating factor. Yes, it's important. Somebody tells you that, yes, actually what happened was he was beaten by somebody. Something likely happened. Or he fell down and he hit his head. Something like happened. He needs medical attention straight. Or somebody, yes, we are playing football. He was with me in the field. Probably it's because of severe heat. This guy has, what do you call it? Seizure disorder. What happened? What is the precipitating factor? Obtain information about medication and their side effects. Yes, it's very important. We should know the medication these guys are taking. So some of the things we see in the patients that we manage as therapists come as a result of the side effect of the medications they are taking. Not because of the epilepsy itself or seizure, but because it is the side effect of the drug they are taking. There is no therapy test and measure specific for epilepsy. Therefore, physiotherapist has no test specific for what? Epilepsy. We are only going to know the kind of presentation. Is this tonic-clonic? Is it atonic? Is it myotonic? Is it, what do you call it, simple partial? Is it complex partial? What is it? We should note by the way they tell us the presentation. the way the child used to fall, but we don't have a single test, the physiotherapy test for what? Epilepsy. Okay? Therefore, assessment should be based on medical condition which the referral was made. Therefore, at times, the assessment is just CP, but complicated by what? Epilepsy. Epilepsy, because nobody is going to send an epileptic patient to you for management. But at times, due to research, day and day research, we now begin to invite people with epilepsy to come so that we do research with them to see whether some of the modalities we use for treatment can help them. Then, okay, medications commonly used in pediatrics. Yes, it's very important. Now we have valproic acid. If you have a mother, okay, we did not digress too much when we are discussing antenatal. Valproic acid is what we call folic acid antagonist. Any woman that is taking valproic acid, she is likely going to have a child with spinal bifida because it's a folic acid antagonist. Therefore, when the woman tells you that I'm taking valproic acid, meaning that the mother herself is having what? Seizure or epilepsy. It's a drug for epilepsy. Therefore, if a pregnant woman is having epilepsy and they give her valproic acid, then the valproic acid is what? A folic acid antagonist. And then the child is not likely going to have this either what you call it, may not have seizure, but may come up with what? Spinal bifida. Then we have clonazepam. Please, the name outside valproic acid is the generic name. Then the company name is Dipakin. Therefore, the way I do it is that the original name is the generic name is outside the bracket, while the company name is inside the bracket. We have clonazepam. Then we have valproic acid. The side effect is tremor and dizziness. Therefore, you now come to manage a child and you see the child's hands and legs are moving. You feel as if it is a physiotherapy that is giving him. No. It is probably because of the valproic acid. Then we have clonazepam. They said it causes drowsiness, meaning that a child with clonazepam is likely going to come to the physiotherapy department sleeping. Then you and the parents will now have to agree on when the child should be given clonazepam. Probably they will now say, any day we are coming, the child is going to take the drug in the night. By morning, they come for physiotherapy. Not that the child takes the drug in the morning and come for physiotherapy. Okay, that is called tonic-clonic absence and complex partial. Look at it, tonic-clonic absence and what? Complex partial. They use these ones. Then they said generalized tonic-clonic and partial seizure. The medication, they use phenytoin. I am used to seeing phenytoin in children that come for physiotherapy management. They said they have either generalized tonic-clonic or what? Partial seizure. Usually the phenytoin, carbamazepine, that is Tegretol. Tegretol is also given to adults. Cool? Then we now have phenobarbital, that is Lumina, then primidone, misolin. Therefore, each of them, you can see they have their own side effects. Therefore, when a child comes, the side effect may be that of, may not be that of, seizure, may be that of the medication. Here we have for absent seizure alone, the medication is a tosuxamide, and they said it has no side effect. Myoclonic seizure, the one that involves jerking of both upper and lower extremities, we use phenytoin, that's dilantin and clonazepam. All of them, we know their side effects. Cool? Then we now have static epilepticus. They said the drug of choice is diazepam, Valium. Therefore, we can now see that we saw diazepam in two places. The first diazepam, where did we see diazepam in the first place? Management of spasticity. Today we can see diazepam in the management of what? Status epilepticus. It's good. We know the drugs. Until you see diazepam, you know. Is he having epilepsy? Is it for spasticity? You should know. It's very, very important. Okay, physiotherapy approach to management. Here, in normal clinical setting, no child is being sent to physiotherapy for management of what? Epilepsy. Usually, the doctors manage epilepsy using drugs. Not also. But there are researches now. Majority of the researches are in adults. And researchers have shown that aerobic exercise of varying duration actually improves cognitive function in this guy. Please, one of the complications or the side effects of prolonged, seizure that leads to adulthood is that these guys will end up having cognitive problems. Some of them they are candidates for having Alzheimer's disease. Just like we have another condition we call Down syndrome. Down syndrome individuals are predisposed to having cognitive impairment in their adulthood. The same thing with these guys. If it is not managed, they are also predisposed to having cognitive dysfunction. Therefore, researchers have shown that we have the first one, systematic review by Dunabetia, et al. 2022, those 2 years back, found that moderate aerobic exercise lead to significant decrease in seizure frequency, but significant improvement in quality of life. Okay, what they said is that moderate aerobic exercise lead to non-significant decrease in seizure frequency. What they mean is that aerobic exercise did not reduce the frequency of the seizure the patients are having, but they have found that it improves the quality of life and psychological functioning in these guys. Meaning that it improves the psychological functioning, anxiety, depression that they have, it improves, their quality of life improves, but it does not improve their seizure frequency, meaning that the frequency of the seizure did not change. Another research have shown that exercise improves cognitive function in epilepsy through the enhancement of brain-derived neurotrophic factor in the hippocampal gyrus. It induces neurogenesis and inhibits oxidative stress. But specifically, there are 2 researches. I was a bit late in bringing so many researches, but you can read further. There are 2 researches that are conducted by Iom et al., one in 2014 and one in 2016. The first research was conducted in children with epilepsy. They found that 4-week structured exercise program was successfully implemented in children with epilepsy, and they found that there is no clinical symptom that shows worsening of the condition. The first thing in clinical trial is that the kind of condition you are managing should not become worse with the management technique you are applying. Therefore, in this case, the management technique is exercise. The research has found that the 5 weeks of structured exercise they give the children with epilepsy did not actually make their condition worse. What is then the positive side again? They said there was beneficial impact on cognitive and psychobehavioral functions. They found that there is improvement in cognitive and psychobehavioral function. They said it was recommended that exercise therapy should be further evaluated as part of comprehensive treatment program for children with benign epilepsy. Now, this benign epilepsy, go and read about it. The benign epilepsy is the epilepsy that we call Rolandic epilepsy. It affects the precentral gyrus. It affects the Rolandic cells, giant pyramidal cells of beds. Usually, it's also a kind of type of epilepsy. They call it benign epilepsy. Usually, it's not a disabling epilepsy. They said the child can overcome the epilepsy during adolescent years. Immediately the child reaches adolescence, with good medication, he go over the epilepsy. Therefore, these are the candidates for this research. The next study, the same by Iom et al. 2016. Now, initial study was done for 5 weeks. They now realized why, since they did not have any unwanted side effects of exercise on this thing, why shouldn't they add the weeks? Now, they evaluate the effect of 35 weeks of exercise. Now, instead of 5, they now do 5 times 7, 35 weeks of exercise, and its efficacy of neurocognitive and psychological function in children with benign epilepsy. Okay, now, what they found is that there are improvement in sustained and divided attention, that is cognitive function, and inhibition and disinhibition ability. All these ones are cognitive function. Therefore, majorly, I told you, assessment of cognitive function is not a domain of physiotherapy, but we will find time to find instrument to assess cognitive function, most especially the Wechsler scales. These people now come with a recommendation that long-term exercise intervention may have benefit in some aspect of neurocognitive and psychological function in children with benign epilepsy. In essence, what we are really saying is that it is now true that we can come up with our exercises that involves children with epilepsy, if they are able to, if they are medically cleared, exercise has shown promising, efficacy in the management of children with epilepsy. That is the only modality of physiotherapy that is being used. Exercise has the potential to decrease seizure frequency and improve cognitive, psychological function and quality of life in children with epilepsy. Thank you, and I wish you all the best for listening. Okay, now questions, comments, contribution from the first lecture. We are able to finish 4:25 at least. I was targeting 4 o'clock. Thank you for listening. This is, we said this can be a foundation for us to read further on epilepsy. We can always read further on the, there is more research on adults with epilepsy compared to children, actually. The researches in children with epilepsy are fewer compared to those of adults, but it has been confirmed that aerobic exercise, especially moderate aerobic exercise, improves outcomes of epilepsy in adults. But there are few researches in children, and we hope one day, with more and more researches, the therapists can have the ability to get patients with epilepsy so that they can manage, benefit from our services. And importantly, we have said it, that epileptic patient may not come to physiotherapy for management, but patients with cerebral palsy may come with comorbid epilepsy. Therefore, from the drugs they are taking, from our knowledge of side effect, we should know that this is coming from epilepsy or this is coming from the side effect of the drug the patient is taking, and we should be able to handle them appropriately. I wish you all the best for listening, and we have hope we have just done justice to the topic of today's workshop. Thank you very much.
Thank you, sir.
Thank you.
Thank you, sir.
Okay. Okay.
Please, I have a question.
Okay, somebody was asking question. Hello, I'm
Yes,
with
I
you.
have a question.
Okay, let me answer one question before we go. Somebody was asking peripheral hypotonia and central hypotonia in children with with cerebral palsy. Whenever you say hypotonia, you know there is increase in muscle tone. Hypotonia, one thing is that it is not a straightforward thing. Hypotonia can be in form of spasticity, can be in form of rigidity. Rigidity has a different cause. Mostly rigidity is extrapyramidal. It has to do with, that is where my little problem is. It has to do with, spasticity of both agonist and antagonist muscle. And you can have late pipe, cogwheel, and rigidity, usually as a result of basal ganglia affectation. While spasticity is more of only cortical affectation. Therefore, if I get you, it may be either spasticity, it may be rigidity, but the issue is when you say therefore, that is if I can get you, the one that is usually peripheral that affects only the limbs, usually is the one that is mostly pyramidal. The one that is extrapyramidal, it is not central. It can affect the whole body, like in dystonia, in atetosis, and in these guys, it's usually hypotonia of central in origin. I hope I should be able, I was able to say something. Okay, the next person. Hello. Hello. Hello.
We can hear you, sir.
Okay, somebody was asking a question and I asked her to stop. I was answering somebody. Please, can you ask your question?
Sir.
Okay.
Okay, sir. Good evening, sir. Thank you for the lecture today.
Thank
sir,
you.
please, between SDR and phenol.
SDR.
Now, yes, selective dosal rhizotomy.
Yes. And what?
It takes selective dosal rhizotomy removes the sensory, but the motor is still there.
The motor is still there.
Phenol, yes, but phenol actually causes an irreversible paralysis.
It causes irreversible paralysis. Yes.
Now, that paralysis to the nerve, does it affect both the motor and the sensory?
Usually, if it is mixed nerve, an obturator nerve is a mixed nerve, it can affect motor and sensory.
Okay, now I'm looking specifically at
what they are saying, if you read the literature, ma, why I think they use it only on the obturator nerve is because they can get other branches of the nerves.
Okay.
Therefore, they don't have single branch. Therefore, if they do neurolysis on only one branch, if it has only one branch, then the whole muscle will become paralyzed.
Yeah, completely paralyzed.
Yes, I think why it is only done in only obturator nerve is because it may have other branches that they can do the neurolysis.
May regrow. Okay.
They will regrow. Yes, that is it.
And start
I think they are very careful. Yes, they are very careful. Even the sensation, since other branches of the nerve may be there, the sensation may be affected but may not be totally lost.
Okay.
Yes.
Okay. Unlike in SDR.
Yes, unlike in SDR. Okay. Because in SDR, only the rootlets, and usually is the dorsal rootlet that will just be
the
sensory
removed.
Yes.
Okay. Now, sir, for most of the biggest problem we have with our CP patient are those ones with spasticity that you find out that the increased tone is injuring functionality, injuring balance, injuring movement, injuring posture. Now, for Botox, at what rate can Botox be considered excessive dosage that will make one to now start thinking of SDR?
Okay, what usually happens is, in Botox injection, normally they use it for focal spasticity. Like for a child with what do you call it, cerebral dysplasia, they found that hamstring is our major problem. Yes, therefore they don't. Yes, they're not working, and they found out that individual is just having focal. If we work on, let's say, the hamstrings, and we are able to relieve the spasticity in the hamstring, this guy will be able to stand. Then he's a good candidate for Botox injection.
Okay, sir, but you mentioned something along the line of the lecture. You said if a patient is checked, is examined, and you feel that the Botox, botulinum toxin, it's at
that is a small child, man.
Okay.
It's a small child. A small child that, actually, they used to give it per body weight.
Yes, okay. Okay.
It is given relative to body weight.
Okay.
Hello?
Okay, so when the body weight is such that, I'm with you, sir. I'm hearing you, sir. Hello, sir. Hello, sir. Hello, sir. Hello. Hello, sir. Hello, sir. Hello, sir. Hello, sir. I can't hear you, sir. Hello? Hello, sir. Hello? Hello, sir.
Sorry, maybe they are fixing their problem. We can exercise patients more. Just contact them from WhatsApp.
Thank you. Okay, thank you, sir.
Just exercise patients more.
Thank you so much. Hello.
torí mo rí pé ọ̀rọ̀ èèyàn kan wá mú asset ní ọ̀fẹ́ mọ́.
Hello.
Hello, can you hear me now?
Yes, I can hear you, sir. Thank
Hello.
God. Yes, I can hear you. Sir, I can hear you. Can you hear me?
Okay, yes.
Okay.
Yes, I can hear
So
you.
you were talking about the
Yes.
child being an infant.
Yes, therefore, and then they now come to a conclusion that they want to give him Botox injection.
Yes.
And they found out that the dose they want to give relative to the weight of the child, that the dose is is too much for the child.
For the
I mean,
child.
probably, yes, then they may not end up giving him the Botox injection.
Okay, so they may now go for selective dosal rhizotomy.
No, usually they will say, okay, they will now look at they will look at the benefit or otherwise of other types of treatment. They may say, okay, let's look at phenol injection. Let's look at this. Let's look at, because actually phenol and Botox injection, they are the ones that are meant for focal treatment.
Yes.
For focal treatment, you just identify a muscle group and you work on it. That is all.
Okay.
Like,
Okay,
for
finally,
example, okay, like if you look at SDR, SDR is not meant for one muscle. Like for somebody who is having
not at all.
Yes, it's for all the lower limb.
Lower limb, yes.
Yes, like intrathecal baclofen for somebody who is having quadriplegia and all the limbs are affected. You can see it can go generalized since it is given in the spinal cord. Yes, therefore those ones are the ones that are meant for focal. If this one did not do because of the size of the child, then they can go for the other one.
Other one, okay. So finally, sir, I have a patient. Duchenne's muscular dystrophy. Very now walking. Yes, now walking on toes. Very tight, contracted Achilles tendon. Of course, you know that the entire calf muscles are contracted as if they are strong, but we all know they are not strong.
And they work on toes. Yes.
Yes. So, sir, in this kind of condition, how would you consider the option of serial casting, knowing surely well that the muscles are not actually strong, they are weak and they are fibrosing? Could it be of any benefit? Because the contracture in the tendon Achilles is so bad that passive stretch cannot even give you anything.
No, I think in this condition, I think even in part of the treatment for what do you call it, Duchenne muscular dystrophy, serial casting has never been mentioned, even in the literature.
Okay, but is it possible to consider it? I'm with you, sir.
Hello.
Hello, sir. I'm with you.
Hello.
Hello, sir. I can hear you. I can hear you, sir. Hello, sir. Hello. Hello.
Hello. Hello, sir. Hello, sir.
Hello, sir. Sir.
Hello?
Hello, sir. I'm
Hello?
with you, sir. Yes, I can
Hello?
hear you, sir. Hello, I
Yo,
can
are
hear
you
you,
with me?
sir. Yes, I can hear you, sir.
Yes. If you read through the literature, there has never been any place where they prescribe serial casting for individuals with decayed muscular dystrophy.
Yes,
You
but
know
what
the best
can we do?
option.
Can it be an option?
Hello?
Hello, I'm with
Yes,
you,
the
sir.
best option, with the, hinge AFO, the one we show on the slides.
Yes,
The one
edge
that
careful.
actually can allow dorsiflexion but does not allow plantar flexion.
Plantar flexion, yes.
Yes, what we do is when they come to the clinic, we do all we could. We now fit that orthosis on them. They will now see how it is being used. They will now be using it as night splint in the house. Whenever he is going into sleep, then they will massage the leg, apply that thing. It will never allow the leg to come into into plantar flexion. Then in the morning, he does whatever he do. Hello?
Okay, sir, this patient is a 10-year-old patient. And there's severe, very severe toe walking. 10-year-old. So even if we give an edge scaffold now, he cannot.
Yes.
Sir?
Yes, what we are saying is it the one with the muscular dystrophy? Yes, is it the one with the muscular dystrophy? Is it the one with the muscular dystrophy?
Yes, muscular dystrophy. No, he's the same one. The same one with the muscular dystrophy. He's a 10-year-old child, and he's so bad now. The toe walking is still very bad. The TA is contracted. So, and we're looking at, even if we give an edge scaffold, it will still stand on toes with the edge scaffold because the extent of contraction in the TA is very bad.
Okay, what will happen is at times, what we do is, because this one is, I said we should use the AFO, that is the hinge AFO. If the hinge AFO can be used as night splint, not coming for treatment, night splint.
Okay.
Therefore, it should just be worn in the night and you sleep with it. Then gradually, now see what we can achieve. Because one thing with the muscular dystrophy, you can never stop them from working on toes because they are always, the trunk is not strong. It is as if they will fall forward. That is why their shoulders are usually put behind so as to stabilize. Therefore, what is there is, I advise that that thing should be used as night splint. We can start with the stretching, then later we can use the hinge AFO, hinge ankle foot orthosis, the one that come with a joint that allow only dorsiflexion, no plantar flexion. Then it can be used as night splint for some time, and we see what we can achieve.
It's okay. It's okay, sir. It's okay. I'm just really, it's really a very, very bad one. Can the edge scaffold, can it actually stretch the TA overnight?
No, it cannot. What happened is you cannot stretch it at once. Even having it, one thing, the best option is, like, for example, if I should ask you, if you stretch it with your hand, does it actually give way as in to have some dorsiflexion?
Okay, so when the patient came, we actually did some passive stretching. We did some passive stretching. We were able to get a little, and based on that, we encourage the parents to tell him to keep trying to put weight backwards and keep the heel down a little, which the boy was aggressive about and was trying to do. So the next time they came to clinic, the mother was reporting that, oh, it's a little bit better. But the only thing I observed is it was increasing his imbalance. So there was more fall. They normally push forward, drag the shoulder back to get
in
balance.
order to maintain balance. Yes, they push forward to maintain balance. That is why trying to manage that particular, what do you call it, TA tightness issue will be a bit difficult, because the most important thing is we shouldn't allow that tightness reach the state it is. If we allow it now, taking it back will be a little bit difficult. Yes, because they are now the entire balance is on the toes.
Yes.
Without the toes, this guy is never going to walk again.
It will keep falling.
That is why I encourage it as night splint. When they use it as night splint, then in the morning when they remove it, at least to some extent, even if it does not reverse it, but it will reduce it to some extent.
Reduce it. Okay. Thank you so much, sir. I really appreciate it.
Thank you.
I'm grateful,
Thank you,
sir. Thank you.
So now good.
Yes.
Thank you.
How?
Hello. Okay, in the absence of further questions, let me also take some rest. I wish you all the best until we mix in the next schedule. I wish you all the best. Thank you very much for listening.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
So grateful, sir.
Thank you. Until we meet in another our equality module. This time around, I
Okay,
was
sir.
busy almost for a whole month. I was the one anchoring. So I wish you all the best. We are still having another one next week, after which I'm going to have some rest.
Okay, sir.
Thank you.
Thank you.
Thank you, everyone.
Precious is crying. Go and open it. He's not coming. Is it not Treasure bringing Precious? I heard Precious voice cry. Oh. Let me off this thing.